Good morning. I'm humbled. I'm truly humbled. And all the things spoken about me have come out of the love and affection they have for me. Not that I truly deserve it. And I must say kudos to Dr. Saravanan, the chairman of the Sirio Group of Children's Hospital. I know how difficult it is to run a children's hospital in private sector. He has done it fairly well. Kudos to you. I have been running, or perhaps in charge, of a children's hospital at Coimbatore with the help of a lot of philanthropists, Freemasons, industrialists, etc. For nearly 35 to 40 years. I must tell you, I'm still finding it to make both ends difficult to meet, both ends. So I don't know how you do it, Dr. Saravanan. Maybe I will send one of our officers to your organization to learn some tricks of the, I don't want to use the word trade, or business, or perhaps profession. And I would also like to thank Dr. Vinod for asking me to come over here to deliver this oration. Moment he came over, invited me, I readily agreed. The reason why I readily agreed, statistically speaking, I don't think I would ever get invited again because I'm 86. So moment the invitation came, I readily agreed, and thank you for that. And as a matter of fact, I was just looking for the mentees of Professor Rajagopal. I just met just a few minutes ago one of the mentees, just listened to him. I asked him, what is that you would remember about your mentor? Tell me one just the significant feature or a characteristic. Without any hesitation, he said compassion. Without any hesitation, he said compassion. I have chosen the topic for this lecture, compassionate care. I'm not going to speak to you on any medical or technical subject, compassion. The reason why I have chosen this topic, about a year ago, in the month of March, to be precise on the 12th of March, there was an article that appeared in Hindu, and that article was written by no less than the Nobel Laureate for Peace, Dr. Kailash Satyarthi. That article mentioned about the compassionate care, we should become part and parcel of the medical profession. And that article went on to mention so many other things about compassion, which I touch a little bit later. So that's the topic that I'm going to speak. And I've already thanked your academic coordinator, Dr. Vinod. And this is the hospital, I give you the greetings from hospital. Right at the bottom is my mentor. As a Professor Arnold Reinhard is no more. He passed away about 5-6 years ago as a chairman of the Department of Pediatric Medicine at the National Children's Hospital, one of the largest children's hospitals in the USA. The obituary note said, the world has become a bit darker. That's all it said. If you ask me, no mentor ever dies. The only physical frame goes away. On the other hand, they live in the minds of their trainees. They live in the minds of their mentees. They live in the minds of their colleagues. So the mentors and teachers live forever. And coming to Professor Rajagopal, I think I do remember him very well. 3 years senior to me, but always remember him whenever I met in the conference. Very tall, very stately person, always smiling countenance, always very soft-spoken, but absolutely dedicated to the discipline, which you all heard. And the best tribute that I can give it to him is perhaps borrow a couple of lines from Thiruvalluvar and perhaps quote that, I don't want to translate that Thirukkural in English. In Takkar Thagavalar என்பது அவரவர் எச்சத்தால் காணப்படும். I think that's the best tribute. Takkar Thagavalar, worthy or unworthy, noble or ignoble, praiseworthy or not praiseworthy. How do you know? What you leave behind, the legacy. There are Tamil scholars who interpret the Tamil word very differently. Etcham to me means legacy. So he has left behind a rich legacy, not only his family and so many mentors, and so much for the pediatric medicine to grow and prosper in this part of the city, in this part of our country. As a matter of fact, William Osler has been credited with the statement, whenever you think of institutions, universities and hospitals, people always get enamored by the physical magnificence or opulence. But William Osler said, it is not the brick and matter that matters, it's the grey matter that really matters. And true to that, I think Professor Rajagopal lived with that kind of, that's the kind of a thing that you would expect. And see here again it says, the students he has trained, patients he has healed, and the values he has passed on. That's the most important. And of course, here's a picture of Professor Rajagopal. And I have told you this, Takkar Thagavalar. So, I had a good fortune, just like the mentee whom I just met a few minutes ago at this auditorium. I had a good fortune to have an excellent mentor in the form of Professor Arnold Einhorn. I must tell you about his past. Professor Einhorn was a very young man at the time of World War II. And he worked for the French resistance, opposing the forces of Hitler. He joined, during the war, the Institute of Paris, Child Health. He graduated with distinction. At the end of the war, he migrated to North America, and there he joined a hospital. And he was a director there. That's the time I joined. And I would tell you my interactions with this gentleman, how it transformed the life of an ordinary doctor from India going for postgraduate studies. Little later, I will tell you that. Now, see the compassion, the guiding principle for all of us, whether it's pediatrics or any other discipline, as long as you're a medical professional, the guiding principle is stated here in 3 different languages, from 3 different cultures, from 3 different geographies. The noblesse oblige is a French word. My teacher was a French man. So noblesse oblige, the nobility obliges. That's the English translation. The next one, taken from the inscription of some CMC Hospital, to minister, not to administer. As a matter of fact, the first health minister of this nation, Professor Rajkumar Amrit, she went around this country and she visited all the institutions. When she went to Ballo, she felt the air is different here, which I have not felt or sensed anywhere else. What did she mean by that? The air is different. There was a compassion. There was a commitment. There was an involvement. So there was, she wrote in that book, that I feel the air is very different, and that spirit should really be there every part of the world. And then third, Tamil Engadan Panishi Idukidappade. So all these 3 statements, 3 different cultures, 3 different geographies convey the same basic truth, namely to care for the individual with all the dedication, commitment, kindness that you have. As a matter of fact, some years ago there was an editor in the New England Journal of Medicine, Arnold S. Relman, he is no more. He wrote an article in New England Journal of Medicine. There he spoke of dharma of this profession. In North America, during my training, almost all the hospitals were run by the state and federal government. The private hospitals were not that many. Now the situation is very different. He said, dharma of the profession, he said, attend to everyone who knocks at the door. Attend to everyone who knocks at the door. Whether he pays or not, that is not your concern. You are a medical practitioner, you are a professional. We'll come to that. So attend to everyone who comes to you. But then attend to everyone requires resources. Resources are not unlimited. So you may accept payment from those who can. That is how Arnold S. Mann wrote. So these 3 statements convey the same basic message. As a matter of fact, okay. So this was very beautifully articulated at the turn of the 20th century, 1900, 1901, 1903, Sir William Osler. If you ever happen to get hold of this book, nowadays it's not difficult to get hold of the book, Sir William Osler used to go around deliver a series of lectures in Canada, in USA, and also in Oxford, in England. And all those lectures were compiled in a book form called Equanimitas. A very balanced mind. I'm very happy my speech was preceded by three good pediatricians, Dr. Janani, Dr. Pradeep, and Dr. Gauri Shankar. So excellent speeches. So he said, William Osler said, the series of speeches collected in a book, Equanimitas. In that book, he would mention how exactly a doctor should live, what his ideals should be, what kind of approach he should have. All this beautifully mentioned. Of course, I never had an opportunity, but then, see, in his words, let me just read those words of Sir William Osler. Maybe a little bit difficult English, but nevertheless, the message is very beautiful. Loyalty to the best interests of the noblest of callings, and a profound belief in the gospel of the day's work. Somebody asked William Osler, what is that I can do as a doctor? He said, do your day's work well and go home. Do your day's work well, go home. That itself is reward. You very sleep peacefully. Do your day's work very well and go home. And then the hard though conditions may be, there are lots of people complain nowadays. The condition of the doctors are not that conducive, the income is not sufficient, etc., etc. But even 1900 in North America, William Osler had felt the same. Conditions may be hard, approached in the right spirit, the spirit which has animated us from the days of Hippocrates. The practice of medicine affords scope for the exercise of best faculties of the mind and the heart. As a matter of fact, some of you might have read about Socrates. Socrates, a stone cutter, never left a written word. He walked around the Athens and he questioned everyone, and then Plato followed him. Plato took down all his writings, and the dialogue goes on like this, the Socrates and Plato. Socrates asked Plato, what is the function of the ear? Hear well. If the ear is defective, can it hear well? No. What is the function of the eye? To see well. If the eye is defective, can it see well? No. What is the function of the doctor? That question. To heal. If he is defective, if his mind is all the time on the money, can he heal well? No. So basically, doctor, what you are saying, you are a healer. That is why Socrates said, and Plato copied, you take any society, anywhere in the world, regardless of the language, regardless of the religion, etc., you find three types of people are always put on a high pedestal by the society, given extra respect. Who are those three people? A teacher, a preacher, and a healer. Why are they put on a high pedestal? Because for the functions, for the duty, the duty they do to the society, not for the material persons. So basically, we are healers. I think that is something we need to keep in mind. Now, we move fast forward 1965, I joined this gentleman as a trainee, and my life got completely transformed. But 3 years, like Dr. Rajagopal followed like a shadow Dr. K.A.K. That's the mentor-mentee relationship, teacher-student relationship. Indeed, one of the Jewish rabbis had said, describing the relations of the teacher, so very beautifully he said, my son, more than the calf wishes to suck, does the cow yearn to suckle. Very beautiful. My son, more than the calf wishes to suck, does the cow yearn to suckle. My dear student, much more than what you want to learn, I'm actually more interested and keen to teach you. More than the calf wishes to suck, does the cow, more than the calf wishes to suck, does the cow yearn to suckle. So that is the kind of relationship. Now, from this gentleman, I learned a very few fundamental, facts in our profession, in our life. And see, one thing, 4 years of stay with him, money was not in his mind at all. No, it wasn't in our mind either. We were all the time learning pediatrics. We were all the time looking after sick children. That was our thought all the time. The money was never in mind. As a matter of fact, around 10 o'clock, 11 o'clock, there was rounds made by him in the neonatal ward. There was a meconium-stained baby. We were about 14 people from 14 parts of the world, all different colors, different complexions, different heights, etc. And then he suddenly asked a question, how many of you want to become rich? At the end of the residency program, we all raised our hands. We all raised, we want to become rich. He said, put your hands down. I have a suggestion to make. What kind of suggestion, sir? I tell you, all of you go to your respective places, open a dealership for Bata. You will be selling shoes all through your life. You will make a lot of money. You decide whether you want to be a bata dealer or a pediatrician. I got the first message in my life. The first message. Then another message that learned. See, the only time I ever used my native brain to solve the problem was when I wrote the entrance test for the high school. That was about 10 years of age. Of course, the examination was conducted in mother tongue Tamil. That was relatively easy. 2 questions I remember. One question was, if you have a balance with what do you call that? Your balance with the pans on either side. You put 1 ton of cotton on one side, 1 ton of steel on the other side. Which would weigh most? A lot of people answered, steel. No, is 1 ton equal. So my comprehension worked there. I answered it equal. Another question was asked on a clothesline. 10 pieces of dress were put up for drying. It takes 10 minutes for one dress to dry, but 10 dresses how much? Everybody would 100. No, it's only 10 minutes. So that's the only time you see your comprehension. That is, you think on your own, try to answer. Subsequently, all through my college, medical college, etc., it's all memorization, and reproduce, pass every exam. Then it's all rote learning. Even now, when I interact with our residents every morning, I said, don't do rote learning. If the problem comes, you start ask questions. So, is it Socratic method of learning? You must question. You must intelligent, pertinent questions you must raise whenever there's a problem, and then try to get answer to the question. Very beautifully, Professor Gauri Shankar showed those case scenarios. The questions were asked at every stage, and then the answers were. That's the Socratic method of learning. This is that I learned from him, and so, okay. So this my residence has changed my life. Okay, I'm going to give you an example for that. Because this rote learning versus Socratic method of learning. I'm going to just show you a slide. The point in the slide no, this I have to no. The slide, the pointer this. No, okay, wait one. Yeah. Right. This is a movie I want you to watch. Can you run that? Thank you. So I took the permission from the parents. All of you have seen this. Very easy. Very easy. I'm sure all the mentees, Gowers' maneuver. Gowers, a very distinguished pediatrician urologist. And he had a unique gift of writing everything in shorthand. Very unique gift of writing it very beautifully and also drawing it beautifully. And then when he described this maneuver, named after him, Gowers' maneuver. Now it is taught in the final medical school and also subsequently in training. Proximal muscle weakness gives rise to Gowers' maneuver. My question to everyone, I asked my resident also, why proximal muscle weakness gives rise to Gowers' maneuver? Why? Everybody says proximal muscle weakness, Gowers' maneuver. Why? The conditions are listed. That is Socratic method of learning. Why? Because for you to get up from squatting or from recumbent position, your knee has to extend with the quadriceps muscle contraction. Your hip has to extend with the gluteus maximus contraction. Unless quadriceps contracts extending the knee, gluteus maximus contracts extending the hip, you cannot get up. And when these muscles become weak, obviously you're going to use your hands to support. So this is what is Socratic method of learning. Let me give you another example. I'm coming back to Professor Ravi Kumar Gauri Shankar's question. We all see infectious mononucleosis. We see infections. Now there are 2 types of responses to infections. One response is tissue is lost, cell is lost, tissue is destroyed. Hardly any immunological reaction to it. The second one, there is an injury, but there's a lot of immunological reaction to it. Now, you give antibacterial, antiviral agents in the first setup, whereas the second setup, you don't hesitate to give steroid because of immunological. So when people use steroid for in certain situations where infections are there, you don't have to memorize. Again, ask this question because the immunological reaction is much more profound. Hepatitis A virus kills the cells, but hepatitis B virus gives a immunological reaction. So this is what I learned from him, the Socratic method of learning. Then another, okay, the patient care. That's first, I told you the first training. Okay. Another very first year of my training, there was an Afro-American girl who came to the pediatric OP with abdominal pain and vomiting. I was first year trainee, I examined her, found her to be normal. And then I didn't want to send her home because the protocol in the hospital manual said, anyone coming with abdominal pain should undergo urine analysis, a sickle cell, plain X-ray of the abdomen for lead flakes, lead poisoning was very common, and then a sickle cell preparation because 10% Americans are Afro-Americans and they have sickle cell. So I wrote, the first from Madras Medical College, I wrote the requisition, sent it to the lab. 4:30, I got the report. Plain X-ray normal, sickle cell negative, urine showing 4+ sugar and ketone bodies. I wrote diabetic ketosis, admitted at 4:30 in the medical ward. 7 o'clock promptly a call came from chairman. Rama, you are wanted by the chairman. I went to his room. He gave me a seat. He said, are you happy? I said, I'm very happy. Why are you happy? I diagnosed for the first time diabetic ketoacidosis. He said, I am not happy. I asked him, why are you, sir? Why are you unhappy? I diagnosed. No, I don't expect the first resident to know anything in pediatrics. That's not the question. When did the child arrive? At 10:30. When did you admit 4:30? My question to you is this. Why did it take 4 hours or 6 hours to diagnose this condition? I said, sir, I am a neophyte. I don't know anything in pediatrics. No, that's not it. Now, why didn't you look at the urine yourself? If you had only collected the urine at the end of the room, the corridor of the toilet, and clinical acetate tablets were kept in the cupboard, if you had only cared to look at the urine and if you had only cared to perform the urine yourself, you would have diagnosed by 5.5 hours earlier. Something struck me. That is patient care. Not only history, not only physical examination, but the necessary bedside investigation has to be done. And you have to look at the results immediately. Today, when I talk to our resident at the hospital, they say, sir, we are waiting for the lab result. What do you mean waiting for the lab result? We are waiting for the X-ray to come. What do you mean X-ray? Why didn't you in the first place ask for an X-ray? If you suspect pneumonia, you should be the first person to look at the X-ray. If you suspect leukemia, you should be the first person to go and look at the smear. So what is the question of waiting for? No waiting for. It should be part and parcel of your clinical evaluation. So there's another lesson that I learned from him. Now, okay, that morning, this I had mentioned to you. There are 5 fundamental principles you should never negotiate in your professional life. Never ever. Even though I don't practice actively, I still continue to believe, and you must have thirst for knowledge. Every day, you must learn one piece of information in pediatric medicine. Every day. If you don't have thirst for knowledge, better you leave the profession. The second, the Socratic method of learning, I told you. No question of memorization, no question of reproducing what is given in the book. The problems are there. You see, one of the unfortunate things what I have learned is, so many of our parents come and tell so many things in Tamil. So beautifully they express in Tamil. Unfortunately, you don't have English equivalents. There are so many expressions we don't have English equivalents. When you translate English equivalent, you lose the entire essence. For instance, a child came in with 2 days or 3 days fever, the eyes were yellow, and the urine was dark brown. And my resident told me, high-colored urine, sir. What is this high-colored urine? What is high? You want to say brownish dark urine, or yellowish urine, or a pink urine, high-colored. The British fellow wrote it high-colored. So why do you have to copy high-colored? So this is one of the problems. So now, but you must also love your discipline. If you have taken a discipline, you must love it. Be passionate. You must, and then other thing, there are critically sick children. Never give up. Never give up on a critically sick child. Never take no for an answer. You must continue. As a matter of fact, he would tell us, you see children, but then 2 o'clock in the morning or a week later, I will call you, ask you, you must be able to reproduce that child's clinical problem. Once seen that entire problem in your cerebral cortex, I continue to tell this to my colleagues at the hospital, but unfortunately, just last week, a week before last, one anxious father from Nilgiris, he was very worried about his child's problem, And then he had already visited the hospital a couple of occasions, and he asked him, who is the doctor, etc. He told, I called the doctor. The doctor said, I don't know. I don't remember. I said, you had seen the child twice, and you tell me you don't know. What kind of doctor is this? If you have seen a child once, till you die, it must be in your head. Otherwise, it is like a British pediatrician who once said, like a bus conductor. The bus conductors are interested in the passengers only during the travel. They do not know where from they came. They don't know where they're going to go. So your interest is confined to that transient, the journey. But your doctor shouldn't be like that at all. You just think of the patient when he comes and leaves, after that you forget. No, that is not doctoring. You should know all about the patient, because any moment you call, you should be able to respond. You should be able to think. So the money should never be. As a matter of fact, I will tell you in a moment, the money is not important at all. Believe me, even with all this corporate hospital coming up in India, money is not important. Money will come to you. I'll come to that. See, in 68, when I commenced my practice, I had no place. I had no property. I had no money. And they would not give me a girl to marry also. The first thing they ask, they don't ask what is he, how much does he possess. I said, I am well trained. No, he has nothing. We can't give a girl to him. But finally I got married. Doesn't matter. So, I tell you, so the only asset that I had in Coimbatore, the only asset I had, the healing power. I was very confident of my healing power. Remember, when you get your MBBS, MD, DIP, and B, go out in the community, you have a power which nobody else has this. No president has, no prime minister has, no general has. Only you have that power, that healing power. And you can use that healing power to advance in life very beautifully. I will tell you how to use the healing power. This is a 2-month-old baby, 1968. Traveling from Ahmedabad to Coimbatore, 2 to 3 days journey, fever, convulsions, bulging fontanelle. I knew it was pyogenic meningitis. I tapped at the gram stain, gram-positive, gram-negative bacteria. I knew bacterial meningitis. Penicillin, chloramphenicol, pyrrolidinobarbital, 3 weeks. She survived. She became the honor student at the Home Science College. The plasticity of the brain. As a matter at that point, after 1968, I had to request Professor Balagopal Raju, because I was a young pediatrician and they were extremely rich people in Coimbatore. They wanted somebody very senior. And then requested my mentor, my professor, Professor Raju, he came. He asked me one question. How sure are you this is pyogenic bacterial meningitis? I showed him a gram stain. Sir, here is a gram stain. So I would do the gram stain myself. And he was convinced. So that is gram stain. Now the WHO says, it's okay. 75 to 60 to 90%, every 80% of the gram stain in pyogenic meningitis are positive. Simple gram stain clinched the diagnosis, saved the day. Now the another one. Life was ebbing away in a 13-year-old baby. It was in the British type of bungalow house in the area. And I was called by the aunt, an obstetrician. And when I went there, it was a huge palatial building, bungalow. There was incandescent lamp on the top. The whole place was quiet. What I was told over the phone, Dr. Ramaswamy, my nephew born after 20 years, he cried for about a day. After that, he stopped crying. We are worried he is dead, so why won't you come? I went there, hardly any movement. I mean, I thought the baby was gone, but I went very near, there was a movement. And I was trained to one of the techniques in examination. You straight away put your stethoscope on the precordium. You know, don't worry, even with a shirt. I can show you a video from Boston Children's Hospital. Even with a shirt on, you can put your stethoscope on the precordium because you want to examine the heart immediately. Moment I had placed the precordium over the precordium, I made my diagnosis instantaneously. It was supraventricular tachycardia. How do you diagnose it? You know, normally when you listen to the heart sounds of babies, there is a variation with movement, variation with crying. Slows down, speeds up, that's called normal sinus, rhythm variation. That gets abolished in supraventricular tachycardia. Indeed, Alexander Nadas would say, you put a timepiece or an alarm clock under the pillow and tick, 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 it goes on. You make your diagnosis instantaneously. So I did an ECG. There were only 3 ECGs at the time. There the ECG. I had brought an ECG machine with me from North America. There are only 3 ECG machines in Coimbatore. And gave the child the digoxin, and then child did very well because now you use adenosine. So that is, and then near death. So this is where the whole scene changes. Simple dehydration, which you do very easily nowadays, WHORS and IV. Are you still with me or are you all asleep? If you're still with me, may I go on? Okay, fine. So simple dehydration, nowadays very easily treat. That time, 1968, almost for 14 years, I was at the Coimbatore Medical College Hospital. I had cried on several occasions at the hospital. I used to go at 7:30. Many of them would not turn up. They would come late at 8:30. Even though somebody I used to stay till up to 4:30, many of them would disappear at 1:30. I was in charge of the diarrhea ward, 14% case fatality rate. Whereas previous 4 years in New York, not even a single child had lost. Reason was very simple. There was no one to look after them after 1:30. That was the only reason. So this dehydration, billionaire's grandchild, I handled. Child recovered. And the lady as I was called, what do you want? I said, my fees has been paid, I don't want anything. No, you should ask something. I'm coming to the healing power. She said, you should ask something. They were billionaires. I said, you are lying in a hospital, has no neonatal ward, no pediatric ward. Why won't you start one? Within 2 weeks, neonatal ward, pediatric ward started. That was healing power. That was the healing power. Okay. So don't forget this healing power. And no, this 6-week-old baby, chartered accountants, he was like a Caucasian, extremely light-skinned, Madhava Brahmins, And the mother used to say, why, doctor, why is he so white? I said, his white's normal, don't get worried. This baby came to me with about 10 to 15 excessive crying and a swelling along the cheeks. It was treated an osteomyelitis. I had learned from mentor, if you have a cellulitis over the cheeks, forearms or the legs, and the skin looks normal, no signs of inflammation, it is not cellulitis, it is Caffey's disease. It is Caffey's disease. And the new bone gets laid on the long axis of the bone, and so that was the Caffey's disease. Even last week we had one, of course, excellent prognosis. Now, this is a wonderful one. I told you, the first concern is attend to the child, not to worry about the status, whether they pay or not. Your mind is completely tuned to attend to the sick child. You are immersed. You are so involved. You don't think of anything else. I was looking at a police officer's child for simple pneumonia. And child required never took any fees because they were working harder than us. And then it so happened, of course I got married, I told you, a little later. I got married eventually. And then I was with my wife and I, we were traveling in a car, a Volkswagen car. It was a November evening, heavy downpour on a broad road. And then suddenly the car got stalled. I couldn't restart the ignition, I couldn't start. So we stayed. There was a bike that came from behind and parked the bike behind my car. And one tall gentleman got out of the car, he began pushing. I got terribly scared. I said, why should somebody come and push my car? I was telling my wife, I said, don't do anything. He pushed my car all the way to my clinic. Rains had stopped, I lowered the window. And then this gentleman, very tall, handsome police officer, he removed his raincoat and a cap, he saluted me. Sir, don't you recognize me? I say, I do recognize you. Don't you think that you had treated my child with pneumonia? And you never took any fee. And the child is now, is very well and she's going to school. And that is the gratitude. That's the gratitude. Again, a healing power. So the gratitude. So the spontaneous. It comes in, see here is, of course, I didn't have the picture, See, thanks to AA, I told the story and the AA produced the car for me and produced a police officer for me and also put the MD6412 car also. So I just told, I said, I was telling my PG, I'm going to speak to them. Sir, why won't you use AA to create a scene? I just gave instructions, AA immediately created the scene. So, gratitude. Remember, we are the only profession where not only you get paid, but they are grateful to you. When you are unwell, when you go to your own colleague as a doctor, without your knowledge, you are grateful to the doctor, right, isn't it? You feel like paying. And this is, Bharata Mata is actually a Punya Bhumi. It is not like other cultures. Many people don't think of it. It's a Punya Bhumi. You know why I call Punya Bhumi? Because average 90% of Indians feel they should give something to the doctor, or something to the advocate. The disease or the legal problem don't get solved unless they're paid. My father used to pay, to our family doctor, never cash. My father was a farmer. Every time something was cultivated, he wouldn't hand over. So I think, that is there in India. That is there. It was bradycardia. She was blue, intense cyanosis in the tongue and 60. I thought I would lose her. But I always used to carry a laryngoscope with me. I never, always with a laryngoscope. So I didn't, so immediately I put the laryngoscope, gave extra oxygen, brought the heart rate to 100. And then got one of my students there, anesthetist. I said, we use a Boyle's apparatus. Immediately connected to the Boyle's apparatus and took us straight to the theater. No question, nothing. I called my ENT surgeon. Look, I have somebody being treated on asthma for 2 hours, but no improvement, going downhill. It could be only one thing, foreign body, nothing could be foreign body. We went in, there was a tamarind seed. We tried to negotiate, rigid bronchoscopy was to do, and then it wouldn't negotiate, tracheostomy got it out. And I went home 12 o'clock, my wife asked, how come you look so fresh? I've never seen you looking so fresh 12 midnight. I said, the freshness comes out of a intense involvement with a sick child. I said, no money could give me that happiness. No, I'm not thinking of money at all. I didn't even know whether they put on. And that girl eventually got married beautifully. And you see, this is what I'm saying. This is the other thing, today the scenario has completely changed. Today, in every city, every town, you have a lot of youngsters like Dr. Janani or Dr. Pradeep. There are so many of them with sub-specialization. They are available. Now, today, you want to be a complete and general pediatrician, you must continue to interact with every sub-specialist who is available. That will add to your knowledge. And this is another, again, coming to that. See, every one institution that is built in Coimbatore is all coming out of simple healing power. Simple healing power. This young child, the leukemic child, and he was initially treated as a rheumatoid arthritis, then came to him on the 3rd week of illness, it was leukemia, and beautifully responded. And of course, I took the help from Madras and Vellore, and then remission, second relapse, child passed away. My involvement with the family was so good, and they were so satisfied. And even though the child had passed away, 3 months later they came. They kept 25,000 rupees on my table. I said, I don't want it. My fees has been, no. You should do something. This 25,000 rupees, we are leaving it on the table, do something. And that is how the Masonic Medical Center was started. Okay? And today it's a 100-bed institution and a postgraduate institution. That's how it started. I'm giving you solid examples where you can use a healing power wherever you practice, and as long as you use a healing power not to enrich yourself, to help the society, to help the community, to help the children. Sky is the limit. Now, this one, yes, so it's a person. This is another very interesting child. So I used to look after so many poor people at the general hospital. The reason I told you why I had cried at general hospital, because I would go to the medical ward at 10 o'clock, very unfortunate. You would see the urine and stool all between the cots. And you would see a sterilizer with the boiled water all the time. They would put things into the boiling water, take it out, they would do an LP. And they would have cut down without the glove. My heart sang, I wanted to run back. I said, this is not medicine. This is highly primitive. You call yourself medical, this is primitive. Anyway, this particular fellow, so that is one side. As Dr. Gauri Shankar was saying, that in a government setup, I would have put in a needle for pneumothorax, I would have done the same thing. Because in the private sector, some constraints are there. So in the private sector, I was seeing all the affluent people. Every affluent person I saw, that healing power helped me to do something. See, here is a 9-month-old baby was called at 6 o'clock in the evening. Only complaint was fever, high-grade fever for a day. He was well previous. No additional complaints whatsoever. He was febrile. He was febrile. I examined him, no positive finding. I remember during my training years, my co-chairman, Dr. Fraud, telling me, if you have febrile infant, you don't find anything, at least do one thing. Look at the urine. Look at the urine at least. I remember that. I just looked at the urine, it was sheets and sheets of puzzles. E. coli. Then those years, we would do immediately an IVP. When IVP, there was a mega blood and mega ureter. They were the richest people. The only treatment would be surgery. They wanted the best person in the world to do surgery. The only person who would do that was Hardy Hendon at Mass General Hospital. I sent the baby at 12 months to Hardy Hendon, Mass General Hospital. And then he was stunned to receive an Indian baby coming with. He said, this hasn't happened. This hasn't happened at all. It's just not possible to diagnose UTI at 1 year. There must be someone trained in my country practicing. So I'm telling you these examples, how beautifully you can be an extremely good doctor, look after them, and how you can use the healing power to raise the standards in the community. So, this is another one. This baby came to me, this is a very important point. Baby came to me for a routine evaluation. I have another lecture. Even if they're completely asymptomatic, I always tell the doctors, how much time do you spend? 5 minutes for a new patient? How many? 10 minutes? No. You should spend 30 minutes for a new patient. You should spend 15 minutes on a review patient. I also insist, unless it's an emergency, you should insist, you must teach the people to come by appointment. Because you must give adequate time to them to evaluate completely, to answer all the questions. You feel satisfied, they feel satisfied. So this baby came to me, I did a routine exam. The femorals were weak. I couldn't feel it. And then baby was asymptomatic. Repeated 4 weeks later, still weak. Eventually turned out to be coarctation. I got her operated at Children's Hospital of Michigan. She is 55, mother of 2 children. So these is several conditions in our system remain hidden, asymptomatic. Nevertheless, they are remediable. They are remediable. So that you diagnose only if you have a thorough physical examination. So thorough physical examination, talking to the parents, etc., takes time. And I'm glad you showed one picture of a red reflex. I'm very happy when I looked at the red picture, because I make it a part of my practice to use an ophthalmoscope at a arm's distance at a time, turn it on every child that comes to me. Now the only reason I do that, even an older child, I don't want to miss a retinoblastoma. Cataract I can afford to miss, my reputation suffers. Indeed, Shakespeare said, the reputation is the immortal half of yourself. You have to build your reputation. So that's the reason why I do red reflex genetic test routinely and asymptomatic. So this should convince you. I am been convinced. I'm 86, I'm convinced. I have a son I educated. I have a daughter I educated. I have a property. I have a car. Compared to millions and millions of Indians earn 30 to 40 rupees a month who struggle to make both ends meet, you are a prince. You are a princess. Believe me, you are a prince and you are a princess. Don't look at somebody. As a matter of fact, I go in a small nano car. I said, why do you go in a small nano car? Nano car, Ramaswamy is important. If I go in a Benz, Benz is important. I want to be important. I want to be important. That's it's as simple as that. The emperors. So, in other words, compassion and competence. I was telling you about Kailash Satyarthi writing about. This English is a second language, it's not my mother tongue. To get into the precise meaning of these words, how to use them meaningfully and with a purpose. I used to read about these words also. Compassion, empathy, sympathy, there are related words, but they're completely different. When you say sympathy, you sympathize, you express concern for somebody who's unwell. When you say empathy, you put yourself in their shoes, begin to experience that. That's empathy. But then compassion is one step more. You not only experience, but you also go and offer help. Offer help with happiness, with kindness, with attention to details. That is what compassion. That's why when the mentee said, one thing that I would remember about Professor Rajagopal is compassionate, I said, knowingly, I know I have chosen the same topic. I said, compassionate care. Compassion, of course, competence is function of the brain and the hand. So now, just another few minutes, I'll finish the lecture. The medical science going astronomically from the day I started. I would be unfit to practice now because the training that I had, I can't use it to practice today or tomorrow. I have to undergo completely a new type of training to practice. Astronomically, it has grown and enhanced the healing power of the doctors. But with this, something else comes to every doctor. They become arrogant. With healing power, technology power, the doctors become arrogant. Not all of them. There is a lecture in New England, arrogance of the doctors. It should never ever come to the doctor. It should never ever come to the doctor. That's what exactly Satyarth, Kailash Satyarthi says. If a doctor is compassionate, the healing is better. The doctor also feels better. So now, I don't know the answer to this. We are sandwiched between hospitals run in private sector where the expenses are very, very high. Only a small percentage can afford. And you have a large number of people who depend on public hospitals. Nothing wrong with public hospitals. But unfortunately, the studies have shown 70% have no faith. This is unfortunate. 70% lost faith in the public institutions. So that is the problem. What is the way out? You are in the devil in the deep sea. Here, I don't have the money to pay. I put my wife for 3 days illness in a corporate hospital. 3 days, it cost me 1 lakh. Because I had the money to pay. I told my wife, hereafter don't become ill like that. So, I said, I don't, so I said, no, so this is the problem. No, I have a suggestion to make there. Okay. Now, there is another phrase that I want you to remember. With 2 more slides, I'll complete. There's a phrase used by former dean of PSG Medical College, where I was clinical professor for a couple of years. He said, the interaction has to be professional, not commercial. Professional meaning you are thinking all the time about the diseases. Commercial meaning you are thinking about the income. So, the way forward, I feel, is to have endowments. The way forward is to have endowments. Many institutions in the world, the East, West, educational, non-educational, Oxford, Harvard, Stanford, Ramakrishna Mission, CMC Vellore, many institutions in the world have endowments. All those who have extra money can create endowments, and the endowment money could be used to treat and subsidize the poor. That's what we believe in it, not in capitation fees, or not investor-owned or equity-owned. Investor-owned, equity-owned means you have to pay them the dividend, it's going to be expensive. So that's finally, that's what it is. And then, okay, this is, if you have created a milieu, whether, especially private, if the doctors are allowed to work without feeling the pressure to generate money, that's possible, that is feasible if you have endowments. So the doctors can feel absolutely comfortable to treat, and so that's what I personally feel. That's what we in our institution are creating an endowment to 10 crores so that 1 crore interest could be used to treat the poor. So we don't want to send the poor away, and you should be proud. So in other words, finally, you should feel very proud. You should be very proud as a doctor. You should be very proud as a member of profession, because as I mentioned, you only have the healing power. None of the other people have the healing power. Use the healing power to enrich the society, to help the people. Okay, now this is, how many of you have ever read or heard about this book? 6-7 years ago, written by the health secretary, Union Health Secretary, forward Amartya Sen, not an ordinary people. They call our profession, are the healers or predators? He said there are instances where they are really healers, but there are several instances where doctors are not healers but predators. This should never ever happen to our profession. never ever happened to our profession. This is a book worth reading. Worth reading. This is where the reference to Rajakumar Amritakar also comes. So this is what. So finally, at the end of the day, these are the books you must have it at bedside for 10 to 15 minutes of reading outside medicine. That includes Bharati, Thirukkural, Equanimitas by Silly William Osler, meditation. You must read this book, Marcus Aurelius Meditation. Very beautiful book. And 5 great dialogues, Plato, Emerson, Oliver Wendell Holmes. These books, if you read for 30 minutes a day, it will change your life completely. So thank you very much for this wonderful opportunity. I hope I have not exceeded the time.
Thank you, sir. Let us give standing ovation to the sir. That was truly an inspiring and provoking, thoughtful, provoking oration, sir. Thank you.
A very good morning to all. As all of you know, urinary tract infection in children is a challenging problem for 2 important reasons. Most of the cases present as a non-specific symptoms, or sometimes it is asymptomatic. So unless otherwise a prompt diagnosis is made, it may lead on to lot of renal problems. Delay in renal growth, poor glomerular function, early onset of hypertension, sometimes it may end up in end-stage renal disease. So about this important topic, Dr. Sangeeta is going to deliver a lecture, and she is from Government Stanley Medical College as an undergraduate, had a postdoctoral fellowship from Mehta Children Hospital, Chennai, had done her PhD at Sri Ramachandra University. She is a senior consultant in the Department of Pediatrics and Pediatric Nephrology, Kaveri Hospital, Kovilambakam, Chennai. She had the honor of having awards, Yuva Star Award 2025 by IAP TNSC, Fellow ISN Award by International Society of Nephrology in the year 2023, ICMR GA grant of, for her PhD in 2022. Her special area of interest is pediatric renal diseases. She had 52 publications in PubMed, and she has authored Pearls in Pediatric Nephrology for the postgraduate Scott Specialty Series. Over to Dr. Sangeeta for further proceeding.
Thank you, sir, for the kind introduction. A very good afternoon, one and all gathered here. I thank the RIO team for this wonderful opportunity to talk on pediatric urinary tract infection in children. So the outline of the talk would include the definition of urinary tract infection, what is simple and complicated UTA, why are they getting recurrent urinary tract infection, and what is the relationship between UTA with the underlying anomalies like vesico-ureteric reflux and bowel bladder dysfunction. What is UTA? It is identified by the presence of symptoms with a significant growth of a single species of bacteria. We confirm this by doing urine culture. We know that boys are generally affected more during infancy. Beyond infancy, female children are affected more. Approximately 88 to 30% of children with the UTA get recurrence of symptoms, and we know that E. coli is the most common organism, followed by other gram-negative bacteria like Klebsiella, Proteus, Enterobacter and Citrobacter. We do get other gram-positive rarely like Staphylococcus, Enterococcus and other viral UTA also. Currently we face this problem, like the bacteria is not responding to the routine antibiotics because they present with this, we see this ESBL growth, extended spectrum beta lactamase producing bacteria. They have inherent resistance to the usual antibiotics what we use like ceftriaxone or other penicillin 2 puff drugs. The prevalence is ranging from 1 to 11% in various studies. Why are they getting ESBL UTA? Whenever a child is having underlying anomaly like PUV, pelviureteric junction obstruction, renal stones, recent hospitalization, instrumentation, or children who are getting recurrent UTI, or because of inappropriate antibiotics, they tend to get this ESBL UTI. Do we see viral UTI? It is rare. Generally, it will be limited to the lower urinary tract, commonly caused by adenovirus, enterovirus, Coxsackie, and echovirus. Fungal UTI only in children who are immunocompromised, who are on long-term broad-spectrum antibiotic therapy and indwelling urinary catheters, they are at risk of getting fungal UTI. We know the pathogenesis is ascending infection, the most common mode of spread of UTI in children. The organism which colonizes the perineum, usually the E. coli, would be the main source of infection. What is the cause for this? The compound papillae, which are situated at the poles of the kidney, if they have underlying dysplastic kidney or vesicoureteric reflux or high pressure system like pelviureteric junction obstruction or neurogenic bladder, the the infected urine can cause immunological and inflammatory response in the kidney. Repeated infection in an anatomically disturbed system can cause renal parenchymal injury, and they can present with a subsequent scarring when they recover from the illness. By inherently, we have certain protective factors to prevent infections in the system. We get this unobstructed urinary transport, which is unidirectional urine flow from the pelvic calyceal system, and we have operative antimicrobial urothelial activity, and the children should be properly toilet trained for regular and complete bladder emptying. Nowadays we see children who are holding urine and they use Vincent's Kersey to hold the urine, and that is the main predisposing factor for urinary tract infection, especially in girl children. Other identifiable risk factors for UTI include young age, high-grade vesicoureteric reflux, posturethral valve, neurogenic bladder, bowel bladder dysfunction, phimosis in boy children, vulval synechia in girl children, and worm infestations. What are the clinical picture? Neonates can present with a sepsis with poor feeding, vomiting, jaundice, temperature instability. Uncomplicated or lower urinary tract infection will be having very mild symptoms like low-grade fever, dysuria, urgency, frequency, rarely hematuria, and foul-smelling urine. When they have this acute pyelonephritis or upper UTI or complicated UTI, they present with a high-grade fever with chills and rigors, persistent vomiting, and lawing pain. Whenever a child is presenting with a recurrent fever, diarrhea, abdominal pain, failure to gain weight, again you should think of UTI, especially in toddlers. When they have underlying structural abnormality, we should also get the history like urinary incontinence, straining during urination like in PUV, poor urinary stream, or anorectal malformations, spinal abnormalities should be looked for. So, in a pediatric clinic, we always give importance for growth parameters, blood pressure, and systemic toxicity signs. In a child, when you suspect UTI, always give importance for looking for the palpable distended bladder, enlarged kidneys, suprapubic and renal angle tenderness, palpable fecal mass in the colon, vulval synechia in a boy, in a girl, and phimosis in a boy child. Complete the examination with the spinal examination. What are the investigations we do to make the diagnosis of UTI? Bedside urine microscopy can be done, or gram staining can be done, as sir has already given the UTI clue. So, pyuria in a centrifuge sample, when we get more than 5 WBCs in high par field, favors urinary tract infection. Nowadays we also have rapid dipstick based tests which are useful as a screening tool. A positive leukocyte esterase test is suggestive of UTI, and nitrate reduction test is highly specific, but false negative tests are common because the urine should stay in the bladder for at least 2 to 3 hours to get this nitrate reduction test. Along with that, we can also look at the gram stain, that is called enhanced urine analysis. Along with the pyuria and gram stain, the sensitivity increases to 85% and specificity increases to 99.9%. And coming to the method of urine culture, though we have these screening tests, urine culture is the gold standard investigation of choice. So in neonates and infants, urine sample should be obtained either by suprapubic aspiration or transurethral bladder catheterization. Whereas in a toilet trained child, midstream urine sample can be collected. When we collect the urine sample, if it is by suprapubic aspiration, the colony count should be 1000. When we do it by urethral catheterization, it should be 10,000, and midstream clean catch sample more than 10,000 to 1 lakh colony count. Even if the count is less, if the child is symptomatic, we can treat them as having urinary tract infection. What are the practical difficulties we come across when we ask them to collect the sample? For that, we have to educate the parent in a simple and clear instruction should be given to collect the urine sample, and wash the hands and urethral meatus and collect the sample after spreading the vulval region in a female or withdrawing the foreskin of the glands in a male child. Ask them to collect the midstream collection, and as soon as they collect the sample, that should be transported to the lab, or else it should be stored at 2 to 8 degrees Celsius. We can get false positive results if it is contaminated from the genital secretion or bacterial overgrowth upon standing. False negative results are also common because of late transport, lysis of leukocytes, or alkaline pH or low specific gravity. So apart from this, when a child is toxic, we may have to go for other investigations like complete blood count, C-reactive protein procalcitonin, blood culture, and renal function test. Ultrasound abdomen is mandatory whenever a child is presenting with positive urine culture. What about the role of imaging in a child who is having febrile urinary tract infection? Ultrasound should be done when the urine culture is positive. If it is abnormal and in children who are presenting with atypical picture like septicemia, poor urinary flow, abdominal mass, no response to routine antibiotics within 48 hours, or raised renal parameters or non-E. coli infection, they should undergo further imaging at a later date. When do we do mixture routine cystourethrogram? Usually we give time about 3 weeks to 6 weeks following UTA. We do this MCU test, and if it is showing high grade of vesico-ureteric reflux like 3, 4, 5, then we have to do dimercaptosuccinic acid scan to look for the differential function and any evidence of scarring after 3 to 6 months of presentation of UTA. This is the recent ISPN guidelines. But when a child is presenting with a recurrent UTA, we have to go for ultrasound abdomen, MCU, and DMSA irrespective of age. And whenever a child is presenting with a recurrent UTA, always give importance to find out the underlying bowel bladder dysfunction. This is the MCU showing bilateral vesico-ureteric reflux grade 2, and this is left grade 4 VUR, and this is about the bladder diverticulum posterior urethral valve in a male child, and this is the duplex system. This is the DMSA scan. You can see this is the normal kidney. Here the affected acute pyelonephritis or follow-up of UTA may show this photopenic areas. How do we treat? We have certain regular antibiotics for treating UTA like cefixime, co-amoxiclav, ciprofloxacin, cephalexin, etc. This is depending upon the physician choice we start. And parenteral antibiotics commonly we use is ceftriaxone, cefatoxime, amikacin, or co-amoxiclav. Before starting amikacin, we should make sure the renal functions are normal. Whenever we change the IV line, we also repeat the creatinine values when the child, creatinine and potassium value when the child is on aminoglycoside therapy. What about treating children who are presenting with the ESBL UTA? According to the up-to-date guidelines, meropenem, ertapenem, or imipenem are the drug of choice. But in practice, we start them on piperacillin tazobactam unless otherwise they are sick enough to be in the ICU. When do we have to repeat the urine culture? Whenever the child is having persistent fever and toxicity despite 72 hours of adequate antibiotic therapy, or when you are suspecting contamination, we have to repeat it. What is recurrent UTI? It is second episode of UTI. What is asymptomatic bacteriuria? Significant bacteriuria in the absence of symptoms of UTI. So we need not treat this asymptomatic bacteriuria, otherwise we will be replacing that non-virulent strains of E. coli, so it need not be treated. It is a benign condition. Let us look at some scenarios and discuss about the management. This is a 5-year-old girl child brought with the history of fever for 5 days, pain during urination. Generally, older children would be telling all the complaints. No history of hematuria, cloudy urine or passage of crystals or mud in the urine. This history is mainly to rule out renal stone disease. No history of vomiting or loose stools. On examination, the child was febrile, but hydration was good. No vulval synechia. System examination was normal. So the diagnosis here is simple urinary tract infection. This child can be treated as OP with oral antibiotics. This child's urine routine was turbid with plenty of pus cells, and urine culture grew E. coli 10 to the power of 5 and sensitive to our routine antibiotics. So counts are high with the CRP mild elevation, blood culture was sterile. So the diagnosis here is simple febrile UTI. Treatment would be cefixime for 5 to 7 days would be enough. Coming to the case number 2, 3-year-old boy with a high-grade fever for 4 days with chills and rigors. He also had vomiting and cry during urination. On examination, he was febrile, toxic, dehydrated. He also had right loin tenderness. Counts were high with the CRP very much elevated. You can also see the dehydration causing elevation of blood urea nitrogen. Creatinine is high. Whenever you see the creatinine level in children, always it is advisable to calculate the estimated GFR. Urine microscopy has shown plenty of pus cells with the proteinuria. Again, urine culture is E. coli sensitive to ceftriaxone. Ultrasound showed right rhinomegaly with the pelvic wall thickening. So this is right acute pyelonephritis. Less than 5 years old children presenting with UTI is acute pyelonephritis. And when you make the clinical examination with a loin tenderness, again it is complicated or acute pyelonephritis. When the child is dehydrated, we have to start them on proper hydration, and IV antibiotic would be better for acute pyelonephritis. This is a 6-month-old baby boy who presented with a fever for 2 days and vomiting, no weight gain for a month. He had reduced urine output and activity. Child was lethargic and dehydrated on examination. There was a history of pyeloplasty 5 weeks ago, and stent was removed a week ago. So whenever the child underwent some surgery in the past, still underlying kidney disease, we would suspect UTI first as the primary diagnosis. And this child had dilated renal pelvis with the solid echogenic floating echoes, which were suggestive of fungal balls. It was very difficult to drain using the directly from the kidney, and this was the cloudy material from the pelvic calcial system, and this was the fungal growth you can see in the kidney. This is the ultrasound image, and the potassium hydroxide mount showing the aspergillus growth, and the lactophenol cotton blue stain showing the aspergillus flavus growth. After treating the child with the antifungal medication, the left kidney has cleared, and the fungal ball was cleared, and the child was put on antifungal medication for 4 weeks. On follow-up, he was doing fine. This is an 8-year-old girl who presented with the dribbling of urine, which was noticed since infancy. She was always on diapers during the day and night, as she was always wet her undergarments. She had been taken to multiple healthcare facilities from 2 years of age, and she received multiple courses of antibiotics, though she never had culture positive UTI. On examination of her genital area, it was wet with the excoriation and it was smelling very badly. She was treated for vulvovaginitis multiple times. She had a regular bowel pattern. She was a well-grown child with a normal vitals, and continuous dribbling of urine was noted when I did the genitalia examination. She also had extensive erythematous vulvovaginal region, and the other system examination including the spine were normal. In a girl child, when they present with continuous dribbling, we have only one diagnosis, it is ectopic ureter. When a boy child presenting with a dribbling for a longer time, chronic, then we have to suspect posterior urethral valve. This child's ultrasound was normal, post-void residue couldn't be measured as she was continuously leaking urine, and to rule out neurogenic bladder, MRI spine was done. It was normal. MR urogram showed doubtful ectopic insertion of the ureter posteriorly, and cystoscopy showed a small capacity bladder because she was continuously draining. The bladder was not trained to hold the urine. The left ureteric orifice was found just below the bladder neck, and right ureter was also ectopically inserted on the wall. Her genitoscopy was normal, and she was continuously dribbling like this when we did the genitalia examination, and she underwent bilateral intravesical ureteric reimplantation, and the catheter was removed on day 6 post-operative day. She became continent and dry at 8 years of age. She is able to hold the urine for 2 hours now during the day. She has also attained nighttime continence. So a simple genitalia examination would have picked up this diagnosis very earlier, but it was unfortunately we could make the diagnosis only at 8 years of age. And the possible ectopic insertion sites would be around caudal to the normally the ureters will get inserted at the trigone of the bladder. These are the abnormal sites. It can get inserted at the urethra, vagina, vestibule, etc., where they will present with continuous dribbling. The same previous child's sibling, who is 10 years old, had febrile UTI at 4 years of age. Ultrasound was normal at that time, and at 10 years she presented with abdominal pain, and urine culture was done sterile. See, you can see at 2019 they have done the ultrasound. Right kidney was 7.2 centimeter, left kidney was 6 centimeter. There is some difference, but still we couldn't make out at that point. But what is the importance of keeping the children under follow-up whenever they have culture positive UTI? And when she presented with abdominal pain, we repeated the ultrasound in 2025. Here you can see the right kidney is 9.1 centimeter, but the left kidney is 6.9 centimeter. Definitely there is a size variation, and the left kidney is obviously small. Bladder was normal. Ultrasound DMSA scan showed less function on the left side. It was only 26%. That is why we should keep them under follow for the next 1 or 2 years, just to make sure the kidneys are properly growing. And it is always advisable to have this kind of nomogram to compare the kidney length, whether it is appropriate for the child's age. It would be very useful for our clinical practice. And the next child is an 8-year-old boy who presented with abdominal pain and vomiting for 2 days. His appetite was poor. He lost around 10 kg in the past 2 years. Past history of recurrent febrile illness, which was treated with antibiotics, but he was never taken to a pediatrician. On examination, he was pale, thin-built and stunted, no edema or hypertension. His hemoglobin was 8 with a urea of 208 and creatinine of 8.1 for an 8-year-old boy. And PTH was elevated, metabolic acidosis. Ultrasound showed small kidneys for age 5 centimeter for an 8-year-old boy. He also had hydroureteronephrosis and bilateral grade 4 to 5 reflux. And the diagnosis was chronic kidney disease. First time we made the diagnosis at 8 years. It is very difficult for the parents to accept the diagnosis. It would have been picked up earlier if the child was properly seen by a pediatrician. Now he is on maintenance hemodialysis. From our side, we should have these values, creatinine for different age group. Again, the creatinine may start rising only after 50 to 75% fall in renal function, but still for the current practice, we only have creatinine, and it is always advisable to calculate the estimated GFR and see whether the child's kidney function is within the range. This is a 6-year-old female child presented with a fever for 5 days, pain during urination, and her oral intake was good. There was a history of febrile UTI thrice in the past. She was evaluated and found to have right acute pyelonephritis. She had grade 4 VUR bilaterally. When we probed the history, the voiding diary showed infrequent voiding, less than 3 times a day, and day and night time wetting. She stands to pass urine and stool, and she was chronically constipated. On examination, she was febrile, urinary bladder was palpable, she also had loaded sigmoid, urine culture grew E. coli, ultrasound showed bilateral rhinomegaly and bladder wall thickening with a significant post-void residue of 30 ml. More than 20 ml in a child, we take it as significant. The diagnosis here is recurrent UTI with bowel bladder dysfunction. What is it? It is an abnormal pattern of urination in the presence of intact neuronal pathways without any congenital or anatomical abnormalities. They voluntarily hold the urine and stools. And the abnormality would be in the phase of filling phase where they present with the overactive bladder, urgency, frequency, or in the evacuation phase. There will be dyssynchrony between the detrusor muscle and the sphincter. So they get this bowel bladder dysfunction, and for this we have to probe the history, otherwise it is, they may just ignore these complaints. And to make the diagnosis, we do ultrasound, thickened urinary bladder wall, post-void residue more than 20 ml. Whenever a child is having persistent high-grade VUR or spinning top configuration on bladder MCU, we suspect this bowel bladder dysfunction. They should be advised for adequate fluid intake, balanced diet with the whole grains, fruits and vegetables. Constipation can be treated with the polyethylene glycol, mineral oil, lactulose, lactitol and others. They should be trained for timed voiding. Every 2 hours to 3 hours they have to empty the bladder, and in children who are having high pressure bladder or high grade VUR, double voiding will help them to prevent that post void residue, and children should train to squat to void. Is there any role of cranberry juice to prevent UTI? This product to prevent UTI in children with recurrent UTI is grade 2 recommendation, because lot of the ingredient required is 36 to 72 grams per day, and it is not uniform availability. We need not advise this, and but nothing wrong in advising that also if they are ready to get the medicine. And circumcision, it is indicated in children who are having recurrent urinary tract infection with vesicoureteric reflux. When would you refer a child to a pediatric nephrologist? Whenever a child is presenting with a recurrent urinary tract infection or UTI which is associated with a bowel bladder dysfunction or underlying abnormalities like VUR, PUV or PUJ, and children who are having renal scars, deranged renal functions, hypertension, they should be under follow-up and they should be treated with the pediatrician and the pediatric nephrologist help. They should be kept under regular follow-up. So to conclude, fever without focus in children, we should suspect urinary tract infection. We have rapid dipstick based tests to screen the UTI, and culture and sensitivity is the gold standard investigation of choice to make the diagnosis of UTI. Bladder bowel dysfunction is an important cause for recurrent UTI in children. We should plan the imaging, radio imaging in a stepwise manner to rule out underlying abnormality in a child with UTI. Children with recurrent UTI, bowel bladder dysfunction and VUR need regular follow-up with the pediatrician and pediatric nephrologist. Thank you very much for the patient listening. I am very happy to take up the questions.
Thank you so much, ma'am. That was an excellent and very informative session. As always, your approach is so clear, practical and easy to follow. I now request our esteemed chairperson to share their valuable comments.
Yes, it's an excellent practical approach for so many problems of UTI in children. And I'd like to know, is there any difference between UTI of male child and female child?
Less than 1 year, male children tend to get urinary tract infection commonly, but beyond that age, female children are getting it. And coming to the symptomatology, there is not much difference. Only in the stream of urine, might get affected in case of PUV. And apart from that, the symptoms will be similar in both genders.
Is there any role in prophylactic treatment of a prolonged, persistent, unresolving urinary infection?
When they don't have underlying abnormality like vesicoureteric reflux, we need not put them on prophylactic antibiotic. But if they have high-grade vesicoureteric reflux, according to the ISPN guidelines, when they have 4 or 5 grade reflux, they should be put on prophylaxis. That too, up to 5 years of age, we can keep them under prophylaxis. But if they don't have underlying VUR, then they might be having bowel bladder dysfunction. That might be the reason, so we have to treat them for that.
What is the lowest age group confirmed urinary tract infection without any associated renal problems?
Any age can get it, sir. Not all children who are getting UTI are having renal anomaly. It is only around 30 to 40% they might be having underlying renal abnormalities. But it is, as a pediatrician, it is very crucial to pick up that population of 30 to 40%. That's why we do the baseline ultrasound. Earlier we used to do DMSA and MCU for all children who were getting UTI, but the recent guidelines is patient friendly and they have restricted only ultrasound. If it is abnormal, we go for MCU, and DMSA also it is very necessary. In my practice, what do I do? Whenever a child is presenting with UTI, I go for ultrasound. And if the age group is less than 3 years or a abnormal ultrasound, I ask them to do MCU. If the MCU is normal, I don't even ask for DMSA. Because with the DMSA, I am not going to decide anything because the system is normal. Vesicoureteric reflux is not there. So if the kidney sizes are normal, I don't even ask for DMSA test.
As you said, there's much hype about cranberry, but you said only a prophylactic use. But they say for recurrent you can use lots of cranberry. It's on the market
sir.
now.
Yes, sir.
But it's mainly of a prophylactic use as far as you concerned.
Cranberry.
Yes,
Yes.
cranberry. Only prophylactic.
In practice, I have never used it, sir, actually, but people are using it, so.
I request
Less than 1 year, Cephalexin, sir. It is available as drops, it is easy to give, but more than 1 year, I always prefer cotrimoxazole.
Of the dose,
2 mg per kg, sir, of trimethoprim.
which is
Cephalexin is 10 mg per kg per dose.
the minimal age for circumcision, doctor.
Minimal age for circumcision, sir. Again, it is decided by the surgeon and the parents. In certain religion, they do even at 40 days of life. So generally, when we don't advise circum unless otherwise the child is getting recurrent urinary tract infection or underlying PUV. Few surgeons prefer to do circum when they do the scopy.
Mostly PUV cases, doctor. The prognosis is not good. They suffer always. PUV cases, mostly they are not feeling good in old age. What's your experience, doctor?
I have seen various range of PUVs, like PUV children first time presenting with 15 years of age or antenatally diagnosed PUV. When we make the diagnosis at 5 months of age, if it is a bladder outlet obstruction in a male child, I don't know whether it is ethically it is very difficult to decide, but as a pediatric nephrologist, I would advise them to go for medical termination if it is a bladder outlet obstruction with a hypodysplastic kidney, because if we make the diagnosis at early age group, like 5th month of gestational age, then the disease will be very severe. And the parents are going to suffer with the baby. Even after the birth of the child, the baby will need NICU care, oxygen support, and the kidney function is also very difficult, and they have to make their mind for primary valve fulguration follow-up. And whenever a child is coming inside the OP with the urine smell, then we think of PUV. And earlier days, they used to come with ureterostomy or vesicostomy. Nowadays, fortunately, we have all size scopes, and we do, as early as possible, we do primary valve fulguration. And when we treat them with the primary valve fulguration and the kidneys are normal, or we are not expecting the normal kidney in those children, but the system, the bladder pressure is normal, and if they don't have secondary vesicoureteric reflux, majority of the children are doing well. And we also look at the creatinine in the newborn period. Majority of the children are doing well, but the risk of going for CKD is 30% in children who are having PUV, and the risk of CKD is very high when they go for puberty because of the muscle mass and the existing kidney function, how much it is there, all are the contributing factors. But the adult studies have shown that they don't have any issues with the fertility. And again, if they are properly treated in the newborn period, the outcome is good in the adult life also. But many tend to have this bedwetting or undergarment wetting even at adolescent age group. That should be treated. For that, we need to have a multidisciplinary team. Bladder stabilization medication should be continued, and with that, many of them are doing well. Only if they have dysplastic kidney with the PUV, then the prognosis is poor.
Thank you.
I request Dr. Prabhakar Navamani sir to felicitate speaker and chairpersons. I request Prabhakar sir to felicitate our speaker Sangeeta ma'am. I request Prabhakar sir to felicitate S. Venkateshwaran sir. I request Prabhakar sir to felicitate M. Balasubramanian sir. I request Prabhakar sir to felicitate Karthikeyan sir. Thank you sir, thank you ma'am. We now break for lunch.
Dr. A. Parthasarathi, Senior Consultant Pediatrician, Paramakudi. Dr. Murugan Jayaraman, Senior Consultant Pediatrician, Apollo Children's Hospital, Madurai. I request our chairpersons to introduce the moderator and panelists.
I like to introduce our moderator and panelist. Moderator, Dr. Murugesh Lakshmanan, Professor of Pediatrics, Head of the Department of Pediatrics, Government Medical College, Pudukkottai. Secretary, Pediatric Infectious Disease Academy, Tamil Nadu Chapter. He did his MBBS at Tirunelveli Medical College, MD at Madurai Medical College. And panelist Dr. A.N. Karthik, Associate Professor of Pediatrics, Madurai Medical College, Treasurer, IAP, Allergy and Asthma Chapter, TNSC. Trained in Pediatric Pulmonology, national trainer, ATM module, allergy module, vaccinology module, national trainer, advanced NRP, speaker in national and state conferences, post held, state EC member, IAP, TNSC 2024-25, organizing treasurer, Sangam Pedicon 2024, secretary, IAP, Madurai 2022, awards and publications, IAP Active Pediatrician Award 2024, Best Doctor Award 2022, 6 publications in international journals. And Dr. Vasanta Malar, Associate Professor of Pediatrics, Government Theni Medical College, Fellow in Neonatal Medicine, undergraduate at Tirunelveli Medical College, PG at Madurai Medical College, awards, Best Doctor Award 2024, 3 publications in international journals, Secretary in IAP TCB 2023, Treasurer in IAP TCB 2022. Dr. Dinesh Babu, MD Pediatrics, DNB Pediatrics, IDP CCM, PICU, Fellowship in Pediatric Diabetes, Fellowship in ECMO. He did an MBBS at Madurai Medical College, MD at Government Trivandrum Medical College, PICU Fellowship in Apollo Children's Hospital, Chennai, PICU In Charge Consultant, Rio Children's Hospital, Madurai. Awards and honors, All India Rank 2 in PICU Fellowship Exit Examination 2024, All India Rank 3 in ECMO Fellowship Exam 2026. Publications, journals, 4 publications in PubMed and Scope Indexed Journals. Books authored, Handbook of Pediatrics, GTH 6th edition, 6th edition. Thank you.
Thank you, sir, for the wonderful introduction. So, good afternoon, and welcome you all for this post-lunch session. At the outset, I would like to thank Pre-Hospital, Saravanan sir, Dr. Vinod, and IAP Madurai for this wonderful opportunity to do this panel discussion on infections in pediatric practice at this event. Thank you. So, coming to this panel discussion, infections in pediatric practice. So, in any pediatric practice, infections always play a major chunk of your number of cases you see. So, real infections and imagined infections. Imagined infections in the sense, many a time parents will bring young infants with the complaint of noisy breathing as a URI, and many a time antibiotics will be written for that, particularly in the primary centers. If you see, many a time you will still see babies written cotrimoxazole. Even a 1.5 months old baby, 2 months old baby written cotrimoxazole. Ultimately, if you inquire, it would have been just a simple noisy breathing for which the mother attributed to a URI because she has some noisy breathing. So it's very pertinent that we separate infections and non-infections, and again in infections, viral from bacterial. And in pediatric practice particularly, when it's not always the pathology we deal with. Again, we have to deal with the plethora of the parental relatives. Nowadays, with the small families, many a time it's small, only 1 or 2 children. What happens is the anxiety level goes up. Many a time, a 2-month-old infant is being brought by the father, mother, the extended family of the both side grandparents. Everyone come and have their own interpretation of the illness of the baby. And the pediatrician put us enormous pressure to give a quick fix. So, it is high time that young pediatricians develop the nuance of differentiating between a viral and a bacterial infection, right? And also effectively communicating to the parents and convincing them that it's a viral infection, does not require antibiotic. That skill we have to develop as a young pediatrician. It's very important because if you're not going to convince, because 6 of them will be there. Even one is not convinced, they'll go to, within 2 days, what will happen? They'll go to another practitioner with the same complaint and who might give a unnecessary antibiotic or some medicine. So it's very important that we develop the communication skill also. So with that, with small introduction, we go into this panel discussion. For this, we have 3 panelists with us. We have mix of seniors and youngster, Dr. A.N. Karthik, who is a professor at Madurai, and Dr. Vasantha Muller, a professor at Theni Medical College, and Dr. Dinesh Babu, who is a youngster, as an intensivist at Rio. So, going to the first case, this is a 2-year-old child vaccinated as per the UPI, that is the government side who is vaccinated, was brought with high fever, 104 degrees Fahrenheit for 3 days, and a history of incessant cry and tugging at the ears. Right? He was shown to a nearby practitioner, was diagnosed as probable bilateral acute otitis media, and he was started there on oral cefixime, and after 3 days of antibiotics, since the fever persisted and had discharge from the right ear. He had discharge. Now he has, for initially, he had only a ear pain, incessant cry and ear tugging. Now he has a discharge also. So what are your thoughts, Dr. A.N. Karthik, at this point of time?
Good afternoon. At the outset, thanks to the organizers for giving me this opportunity. Coming to this case, it's well a 2-year-old acute fever, irritability and ear tugging. Followed by that, the child had some discharge in their area. So the diagnosis most likely it's straightforward, a case of acute otitis media. But it's not always the same like what we think. Practitioners would agree with me. Because a small child cannot localize the pain. So you can't pick up an ear pain. So it may present with an irritability or sleeping or feeding disturbances. At times in an infant, it can present with a fever alone. So an acute otitis media should satisfy these 3 components. One is acute symptoms. Either it could be a fever or an otalgia. And you have to justify or you have to show the evidence of presence of a middle ear effusion and a middle ear inflammation. A middle ear effusion in the sense it could be a bulging tympanic membrane or the decreased motility of the tympanic membrane or a discharge from the ear. And a middle ear inflammation could be a red tympanic membrane or the discomfort during the normal activity and sleep. The point here is unless you see into the ear to see the status of the tympanic membrane, you can't diagnose clearly an otitis media. So as a pediatrician, in addition to your stethoscope, we all should have a otoscope, and whenever you suspect an acute otitis media, please just look into the ears and see how the tympanic membrane is. So this is a normal tympanic membrane which looks translucent. You can see the handle of malleolus, so which is almost vertical. Whereas you see this tympanic membrane, this is erythematous. The malleolus has become little more horizontal. This you can witness in a simple viral URTI or any eustachian tube obstruction or in with fever too. This is a typical tympanic membrane of an acute otitis media, an angry looking tympanic membrane with bulging, so loss of landmark. So you have to witness this before you start antibiotics, and otherwise you may miss some other serious conditions and you may wrongly diagnose it as an acute otitis media.
So anything more from the history to know what are the pathogens?
As we all
pathogens?
know, otitis media is caused by 3 important bacteria here: Streptococcus pneumoniae, your H. influenza non-typable, and your Moraxella. Though even after the emergence of PCV vaccine, your Streptococcus pneumoniae is still the leading cause. Maybe the non-vaccine serotypes are causing more problems nowadays, but there could be some difference or pointers you could get from the history to catch hold of the pathogen. Streptococcus pneumoniae, generally it will be a rapid onset. You'll have high fever and more symptoms. It is one bacteria which may cause high risk of complications like mastoiditis and tympanic membrane perforation. Whereas an infection due to H. influenza, the symptoms will be little mild, may have a prolonged course, it may even have recurrent episodes. At times it may present with and additional conjunctivitis. So whenever you have an AOM along with conjunctivitis, we generally call as otitis conjunctivitis syndrome, you have to think of H influenza and you have to target your antibiotic to it. Varicella, as we all know, it is one of the mildest and self-limiting. Many a times it often resolves without an antibiotics.
So, well said, Dr. Karthik. So, why are we concerned? Why don't we just take it as acute otitis media and start treating? Why are we concerned? What are the probable pathogens and other things? It's why, because whenever you are going to prescribe an antibiotic, it's not just to know what is the disease process. So, three things you need to know. One is the host factor, what is the organism you are dealing with, and what is the antibiotic you are going to use. So, coming to the host factor, the age decides whether you are going to give antibiotics upfront or we can wait and watch. For example, even this acute otitis media, if it's going to a very small infant, we might need an upfront antibiotic. If it's a bigger child, more than 2 years, maybe milder symptoms, you can wait. So, age, what is the immune competency of the child, how is the severity of the disease, and coming to the organisms, what is the local antibiogram, what is the local, what is the community, what is the MRSA percentage in the community here, the particular community, what is the diagnostic test we have done, how far it's reliable in diagnosing the infection, and the antibiotics, what is the pharmacokinetics, what is the pharmacodynamics, what is the patient have any allergy. All these things play a role in deciding what antibiotic you are going to use and how long and how much. So it's very pertinent that we also think of the organisms, not only the diagnosis, what is the organism we are dealing with. It's very, very important, and it was rightly pointed out by Dr. Karthik, the three organisms which are the most common things. And Dr. Vasnamala, instead of otitis media, can it be a simple otitis media effusion? Is there any probability?
Good afternoon, one and all. I thank RIO team for giving this wonderful opportunity. Coming to the point, whether it is AOM or OME, both AOM and OME are two most common types of middle ear inflammation. So, when it is otitis media, the inflammation is acute and the symptoms will be fever, irritability, ear pain, etc. And it have active infection. And in the otoscopy, the findings will be bulging or red tympanic membrane, as I already discussed. Coming to otitis media with effusion, there will not be any active infection. It is collection of fluid in the middle ear with or without inflammation. And here the symptoms will be hearing loss or plugged feeling. And the onset is also slow, followed by AOM. Now here the otoscopic finding will be retracted tympanic membrane with fluid in the middle ear. So by this history, I will go with AOM for this case. Thank you.
So, as rightly said, pointed out, since the child now has got a otorrhea also, it's most likely to be a otitis media. So at this point of time, will you go for upfront antibiotics, or you can do a wait and watch policy in this child?
So it's a case of 2-year-old.
Which conditions you will do a wait and watch?
Okay. So it's a case of 2-year-old with the severe symptoms, high grade fever, irritability, incessant cry, etc. So for this case, we have to give antibiotics for AOM. So what are the recommendations? For less than 6 months, for all cases, we have to start antibiotics. For 6 months to 2 years, if the infection is severe or having bilateral infection, we have to go for antibiotics. If the case is more than 2 years and mild symptoms, only watchful waiting for that too for 48 to 72 hours, and here antibiotics are not recommended. So for this case, I would recommend antibiotics.
Yes. So the main thing is, when milder disease, you can always wait, right? But when the child develops an otorrhea, it is always an upfront antibiotic. So many times we'll be pressured. So you'll be thinking, so young pediatricians might think, what if the child goes for perforation or something happens, the disease worsens, or sometimes you'll be seeing on a weekend, Saturday, and the child will have only mild pain, but you will be tempted to write antibiotic. What if something happens on a Sunday when we are not available? So what you can always do is, you can always give an antibiotic dose and tell the parent, if the symptoms worsen by tomorrow, now it's only a mild pain, you can always wait for 24 to 48 hours. And if the pain increases or something happens, the child is getting more irritable, fussy, please give me a call tomorrow. I'll tell, you can start the same antibiotic, the dose I have written, and you can always advise them. So that you can always, there's a safety net will be there, right? That and antibiotic safety net will be there, so that your anxiety level also, the parents' anxiety level also come down. That is, they will be convinced, okay, we'll wait for one day. Okay, you can always do that, right? So, Dr. Dinesh, what antibiotic will choose at this point? What will be the antibiotic choice?
Thank you, sir. So for this child, I would like to go with amoxicillin, sir. So basically, as madam has already discussed, so the most common is going to be viral, but among the bacterial, still it is streptococcal infection that is the main cause for acute otitis media. So for that, still amoxicillin is sensitive. And even though streptococcal resistance has been reported, the mechanism of resistance for streptococcus is alteration in the penicillin binding protein. So in those cases also, amoxiclav will not be much helpful if we are suspecting streptococcal resistance. But there are exceptions where we will go with amoxiclav in children who are already treated with beta-lactams in the last 1 month, or the child is having otitis conjunctivitis syndrome where the causative agent is Haemophilus influenza B, and for Haemophilus influenza B, the mode of resistance could be a beta-lactamase. So in those cases, amoxiclav will be helpful. And in children who has received chemoprophylaxis for recurrent AOM with amoxicillin, so in those situations, we will go with amoxiclav, sir. For our child, we will go with amoxicillin.
So, well said. So, amoxicillin will always be the drug of choice. But you might again think, since the H influenza also plays a major role, again 30% incidence is there, 40% of the cases are still strep pneumonia, 30 is this, and the other thing is Moraxella 20%. But the epidemiology is changing. With the widespread use of pneumococcal vaccine, the incidence of strep pneumonia is still coming down, but even in Western countries where the pneumococcal vaccine has been started a long time back, even there the incidence has come down, but still even in your Western countries, strep pneumonia is still the leading cause of acute otitis media, right? So amoxicillin is more than sufficient to cover your thing. Okay, what happens if you miss out a H influenza infection, right? If you take H influenza, 50% of, only 50% of the H influenza are beta-lactam resistant, beta-lactamase producers, right? And as far as Moraxella, 100% of these organisms are beta-lactamase producing. But H influenza, 50% are self-limiting, and Moraxella 100% are self-limiting, right? So if you calculate 30% incidence is 0.3 into 0.5 into 0.5, it's only a 7.5% chance of being a H influenza. Any otitis media you are going to see is only a 7.5% chance it's going to be a H influenza, non-type of H influenza. So the risk is really less. So you can always start on amoxicillin, right? But the thing is the availability. Some of seniors might comment, is plain amoxicillin readily available in the current market, and the number of bottles required, is the dose sufficient? Anyone can comment, sir. Nominee, sir. Amoxicillin, is it readily available? Because most of the companies promote only the amoxiclav, and amoxicillin has become a rare breed to say. Is it so?
I think it's freely available.
Yes. So if you go to the right pharma company, you can definitely get a amoxicillin. But most of the companies, even though the pharma companies do promote, you can definitely get amoxicillin, plain amoxicillin is readily available. As Sir just told, it's readily available. The thing is you have to get it, procure it. That is the only thing.
Now the problem here is amoxicillin falls under price control. So they don't get profit when it comes at a price control. So all the pharma people and the stockists, they always promote amoxiclavulinic acid. As Sir said, amoxicillin, even good companies, it is available. The second point here is high dose amoxicillin, when we need, whether we need more bottles for the same child to procure and give. As Sir said, still the percentage of streptococcal pneumonia resistant to penicillin is still little on the lower side. So many of our outpatient patients can be managed with standard dose of amoxicillin itself. If at all, if you are going for a higher dose, as many practicing seniors will agree, many companies have come up with the extra strength formulations. Instead of 7:1, we have 14:1 amoxiclavulanate, that is 600:42.9, because the clavulanate is the culprit which causes your antibiotic-induced diarrhea. So just by not increasing it, your amoxicillin concentration alone is being increased, and we do have formulations. If it is 600, just think of if you are going to give it 90 milligram per kg per day in 3 divided doses, a 5 ml TDS will work. So still we have in the market, sir. But always it's better to start with plain amoxicillin with a standard dose for simple outpatient practice. This is my humble view.
Yes.
One
So-
small question. Does the immunization status of the child influence your choice of antibiotics? Child is be protected against Haemophilus influenza and
So this is actually a non-typable H influenza. And even though, like I said, sir, even in Western countries with the widespread PCV vaccination, still pneumococcus is the most common organism, sir. So even though the incidence comes down, still strep pneumonia is the leading cause, sir.
Sir,
it doesn't.
after the post-PCV era, that is beyond 2019, studies have come up that the strains which causes otitis media has come down, which are in the vaccine. So the non-vaccine serotypes like 35B and 23B are taking the upfront load. So the bacteria changes itself. Still it is causing the same problem. Though it is coming out, the non-vaccine serotypes are causing more problems nowadays. So that is why pneumococcal vaccine has been being extended from 13, it has become 14 now. Nowadays we are getting 20s is coming to market in few years.
And one more thing, some of you might think, what's the big deal? Amox and amoxiclav, both are almost the same antibiotic. Why don't we use it amoxiclav just as a matter of 20 rupees, 30 rupees extra? So is it really so? One is like Dr. Karthik said, it's the incidence of side effects. The incidence of side effects, the immediate thing is the side effect, which increases. The percentage of cases with the diarrhea following amoxiclav is higher compared to amoxicillin alone. That is one part. And the second part is, when you use an amoxiclav combination, that is the penicillin with the beta-lactamase inhibitor, you are putting a strain on the resistant strains which are resistant to both amox plus beta-lactamase inhibitor. That is penicillin plus beta-lactamase inhibitor. So highly resistant strains which are resistant to both these strains are selectively made out, and they proliferate. And what happens is the increased incidence of these resistant strains are leading to, again, increased usage of the other antibiotics like piperacillin and all the other antibiotics, right? So that is one thing. The remote complication is the increased incidence or resistance to both the things, right? And one more thing, amoxiclav clavulanic acid is highly unstable. In India, where the room temperature reaches very easily in summers more than 25 degrees centigrade in the room temperature, the afternoon and all, this clavulanic acid, when it goes more than 25 degrees centigrade, stored at more than 25 degrees centigrade, within 2 to 3 days, the percentage of active component comes down to even less than 50%, right? But amoxicillin alone is a very stable drug, even at 25 degrees centigrade, even after 7 days, more than 80% of drug is bioavailable. Okay, so again this part is also very, very important. So in amoxiclav, you have to ideally store in a refrigerator, where in a country like India, where the poor households may not have a refrigerator, it's very difficult to store the amoxiclav combination in a very effective manner, right? So that is another point. So child was started on amoxicillin, like Dr. Dinesh told. Child improved on day 3 of amox and advised to continue antibiotics. And again, it was last to follow up like the regular usual parents. Once the symptoms improved, they disappeared from the scene. And after 1 month, they again came back with a non-resolving ear discharge in right ear. So what do you think, Dr. Karthik?
So we have a case of AOM which is started on amoxicillin, responded as per the statement, and now the child has come with a persistent discharge. Could it be a CSOM? I would not take till, because it's just 4 weeks. To say it is a CSOM, you need at least 6 weeks. It's just 1 month, so 4 weeks. Either it could be a non-resolving AOM or recurrent AOM. My vote will be for non-resolving AOM, because the common practice of our parents is not continuing the antibiotics for the appropriate duration. So my first reason would be a poor compliance. It could be an intercurrent infection. We may not know, we need to work up further. In any AOM bacterial cause following a severe viral infection, you may have persistent ET dysfunction. In that time, the recovery time will be little more. That has to be taken into account. It could be a reinfection still. Even in the back of mind, I'll still consider whether I am dealing with a child with a impaired host response, like persistent sinopulmonary infections due to PCD or an immunodeficiency sort of thing. So these things I will think of, sir. Though my first thought will be a poor compliance.
So poor compliance, the patient has not completed the full course. Either we are not counseled, or in spite of a counseling, the patient has taken it very lightly. Most of our parents are like, doctor will say 10 days, the child has improved. The doctor is selling the drug unnecessarily for another 10 days, another 2 bottles is trying to sell us. Okay, we will cut short. And that is the usual attitude of our parents, always doubting the doctor's tendency to prescribe the drugs, right? So it usually happens, and the child has ultimately landed in problems. So what do you think will be the ideal duration of antibiotics, Dr. Vasnapala?
Sir, according, the duration of antibiotics depend on the age of the child and the severity of the symptoms. So in infants and age less than 5 years, the recommendation of AAP and other standard treatment guidelines is 10 days. So 10 days we have to give antibiotics, otherwise shorter duration leads to clinical failure. For children more than 5 years, the antibiotics for 5 to 7 days. That too in case of uncomplicated cases. Even if age more than 5 years, presented with severe symptoms or perforated eardrum or other recurrence, we have to give for 10 days. For this case, I would recommend for 10 days durations.
Yes. So completing the 10 days is very, very important in severe cases. Right? In milder cases, maybe you can try 1 week of duration. Right? So when will you follow? Once you start the antibiotics, when will you follow up, Dr. Karthik? When will you tell the child to bring?
In a case of AOM, whether you treat with antibiotics or not, always ask the parents to bring the child by 48 hours to 72 hours. See what happened to the symptoms, whether it is worsening or improving. Look into the ear for the tympanic membrane, because as madam said, in a bigger child, many a times we opt for wait and watch. Okay. So before you decide on the antibiotics, you re-examine the child's ear. Even if you are starting the child on antibiotics, you have to do a otoscopic examination by 7 to 10 days to see whether the tympanic membrane has normalized. So that is a dictum. In addition, in a children with recurrent AOMs or high-risk children like malnourished or having some immunodeficiencies or chronic lung disease and all, you may need to do a long-term follow-up for the speech, language, hearing and balance problems. So these all things has to be kept in mind when you deal with the otitis media.
So with this, we'll wind up this case. And what I have learned from this is, acute otitis media is the second most common respiratory infection in children, and is also the most common condition which will require an antibiotic in children. Right? Particularly in young infants, it's one of the most common respiratory infection which will require an antibiotic. Right? So diagnosis is mostly clinical by history and otoscopy, and bacterial spectrum is maybe changing in the post-PC era, but still strep pneumonia is the most common now, even now. And appropriate antibiotics for the right duration will help in preventing the recurrence and complications. So with that, we will go to the next case. So coming to facial spaces. Facial spaces are potential latent spaces within the body's connective tissues. They normally do not exist, but form well demarcated when the infection causes these tissues to distend and separate. So these spaces provide pathways for infection spread along the path of yeast resistance. Right? So particularly in children, infection of the face is quite common. In less than 4 years, the upper facial infections, right? So cellulitis are unknown source like the orbital cellulitis, right? Periseptal cellulitis, right? Retropharyngeal, all those things are very common. And more than 5 years, the most of infections are of orodental source, any dental caries and all those things, right? Orodental source is the most common reason for spread of infections. In less than 4 years, it is mostly of unknown origin. So coming to our case, this is a 2-year-old girl, right? With cough, cold for fever for 3 days. It was treated symptomatically. Now the fever has become less, but cold continues. Cough more in the night, irritable, fever on and off for 10 days. On day 12 of illness, the mother comes again. The child is febrile, coryza is there, but chest is clear, right? So could this be a sinusitis, or can a 2-year-old can have a sinusitis? Again, this is another case, similar scenario, little bit different. So, okay, this is a 2-year-old girl with 10 days of continuous symptoms, coryza symptoms. And this is a 4-year-old girl treated as a viral URI 1 week back, normal in between for 3 days. 3 days she was normal. Now she has again fever and headache. Whether it's a recurrent cold or it's allergic symptoms just because the mother says she has a sinus. Most of the time the mother says sinus, it means she has a allergic rhinitis or like that. That is what our people say as sinus in common parlance, right? So, is this allergy we are dealing with, or is it sinusitis? Again, this is a third case, similar case. This is a case of 6-year-old, high fever for 3 days to start with itself. The child has a cough and cold with headache, pain in the maxillary teeth, and child is a bit sick looking, right? So there are 3 case scenarios. What are your thoughts, Kartik?
I'll go with the first case. We have a 2-year-old, right? The first question is whether a 2-year-old can have sinusitis. Right, right. So the point here is we have 4 sinuses. We all know of that. 2 sinuses are already present at birth. So it is always possible for a 2-year-old to have sinusitis. That has to be remembered. Why not less than 2 years? The answer here is any child less than 2 years presenting with a viral URI may have an acute otitis media like symptoms. So we tend to start antibiotics. So the chances of getting it converted to a bacterial sinusitis is a little less. Second thing, the ostia of sinuses are little large below 2 years. So in less than 2 years, generally we don't suspect sinusitis, but beyond 2 years, sinusitis due to a bacterial origin is still possible. So we had 3 different children with 3 different presentation. Whenever you think of acute bacterial sinusitis, either it could be any one of the 3 presentation. Either it could be a persistent symptoms lasting more than 10 days, because any viral URI will settle by 7 days. So when your symptoms are persisting beyond 7 to 10 days, think of sinusitis, number 1. Number 2, when you have worsening of symptoms, initial improvement, then the child gets worsened again with a purulent sputum, fever occurring again, what we generally call as double sickening. So when you have a double sickening, think of sinusitis. And the last, when you start with severe symptoms, like a fever of more than 1 or 2.9, like what the evidences say, with purulent discharge at the onset, a sick-looking child, in 3 conditions, you suspect an acute bacterial rhinosinusitis. So all these 3 cases fit into a case of bacterial sinusitis. Regarding the question of allergy in the mother, every chance of having a small allergy component in the child is also possible. An allergic rhinitis is a forerunner, or I would say it is one of the risk factors for sinusitis and recurrent sinusitis.
Yes. Okay. So, like Dr. Kartik said, allergic rhinitis itself is a risk factor for a bacterial rhinosinusitis. And the first thing, the important thing is, any symptom, like Nelson says, any persistent infection, URI symptoms persisting for more than 10 days is a good operative diagnosis for a diagnostic criteria for a acute bacterial rhinosinusitis. But still, it overdiagnoses by 20 to 30%. What they say is, this diagnosis, working principle, overdiagnosis by 20 to 30%. But the last criteria, even if the child is sick at onset, right? Sick at onset, high fever, even the purulent discharge, even on day 1, right? In usual URI, what happens is, initially it will be watery, and then it will be gradually there will be a change in consistency. That is the entire disease process. The normal disease process URI, from the being watery discharge to becoming a little bit thicker in consistency, that's a natural disease process, right? But here, even at the onset, there will be a purulent discharge in sinusitis in the severe cases, right? So the last criteria is mostly definitely a sinusitis. So how does one manage a sinusitis in your practice, OP practice?
Actually, viral sinusitis will settle on their own. Only supportive care is needed. For supportive measures, for pain relief, we can use paracetamol or ibuprofen. For nasal symptoms, we can go with saline nasal drops or nasal spray and steam inhalation. For our case, we have to start on antibiotics as it is bacterial sinusitis. So the probable pathogens causing sinusitis include Streptococcus pneumoniae, Haemophilus influenza and Moraxella. So the treatment for this is, for empirical therapy of bacterial sinusitis, we have to give amoxiclavam 45 mg per kg for 10 days. Duration is important. For all these cases, we have to give antibiotics for 10 days. For severe cases, we have to give higher dose 90 mg per kg per day. In case of beta-lactam allergy, type 1, we have to go with levofloxacin. For other hypersensitivity, we have to give cefpodoxim plus clindamycin. And in case of severe cases requiring admission, IV antibiotics are drug of choice, ampicillin, ceftriaxone or levofloxacin for longer duration. Thank you.
Yes. So, almost the disease part, the organism pattern is almost the same like an otitis media, right? So, what you have seen is mostly some amoxicillin which are going to use. Any postgraduate, can you say why azithromycin is not there in this treatment? Anyone? Azithromycin, why is it not there? Azithromycin, as you know, is a poor inherent sensitivity to pneumococcus. So it's usually not used for strep pneumonia, and again in India, more than 60% of strains, as per recent studies done in CMC Vellore, more than 60% of strains are resistant for strep pneumonia. So you don't use azithromycin for strep pneumonia suspected infections. You use it only in cases where you have a doubt of atypical organisms. Otherwise, azithromycin does not have a role here, right? So this child, 4-year-old girl, sinusitis and treatment. On day 3 of treatment, she develops this pain and swelling. Right side of the eye, she develops this periorbital swelling. There's a pain and tenderness. Will you admit now? What will be a differential diagnosis?
Yes, sir. So this child definitely needs admission, sir. The reason is, see, this child has received 48 hours of antibiotics and the child is not responding, and the child is more than worsening also. So apart from that, the child is whichever the child who is less than 1 year of age or who cannot cooperate fully for an examination or who are severely ill, are children with subtle clinical signs or radiological findings suggesting that the orbit is involved. So all those cases needs admission, sir. The main reason for admitting the child or to be more aggressive is we don't want to miss orbital cellulitis, and ethmoidal sinus is more notorious to develop into orbital cellulitis, sir.
Yes. So ethmoidal sinusitis is one condition which is notorious to produce this complication of preseptal and orbital cellulitis, right? So a day later, again the disease is being progressed. So how is going to differentiate between a preseptal and orbital cellulitis clinically? Dr. Karthik.
So as Dinesh said, chances of preseptal cellulitis going into an orbital cellulitis is little high. Clinically, it's very difficult. Actually, both have an eyelid swelling, both will have pain during eye pain or tenderness. In addition to that, an orbital cellulitis will have pain during eye movements. You may have a proptosis. You will have ophthalmoplegia, and at times a child may have visual impairment when the disease is very severe. The question is not whether you are going to handle a preseptal cellulitis or orbital cellulitis. Both are rare, but when comparing to adults, the incidence is more common in children going for complications. Whenever you have a doubt whether you are dealing with a preseptal cellulitis or orbital cellulitis, better fix it as orbital cellulitis and treat earlier to avoid unnecessary complications.
So rightly said. So always it is in such conditions where the risk of complications and risk of life-threatening complications are very high in orbital cellulitis, it's always better to err on the wrong side here, right? So maybe a little overdiagnosis may not do any harm because, right, because later later diagnosis might result in make the child land up in complications. Right? Next line. So how are you going to treat a preseptal cellulitis? What will be the antimicrobial choice and what will be the dose and how long will you treat it?
So regarding the pathogens causing preseptal cellulitis, it is Streptococcus pneumoniae, Haemophilus, Moraxella, Staph aureus and Streptogenous pyogenes. So here the first line of antibiotic of choice is co-amoxiclav with the dosage of amoxicillin 45 mg per kg per day. And if you are suspecting MRSA, you have to add vancomycin with this. And the total duration is 7 to 14 days for preseptal cellulitis. And if it is orbital cellulitis, the organisms include Staphylococcus aureus, Streptococcus, and then Aspergillus, Mucorales, and anaerobes. So here we have to use broad spectrum antibiotic covering MRSA and Streptococcus. So we have to go for amoxiclav along with vancomycin. And in addition, we have to use metronidazole for anaerobic coverage until intracranial infection ruled out. And here the duration is 2 to 3 weeks. So for preseptal cellulitis, it is 1 to 2 weeks. Here 2 to 3 weeks. And in case of orbital cellulitis, if bone is involved, then we have to give antibiotic coverage for 4 weeks.
So when you are going to use the right antibiotic, you will definitely see an improvement within 24 hours. Right? So you need not wait long. Right? If you are going to use the right antibiotic in the right dose, definitely there will be if it is going to be a bacterial infection, definitely there will be some symptomatic improvement within 24 hours. So you can very well, and what we have seen is mostly in our place, MRSA little less, I don't think, because in government setup we don't have a lab to differentiate between MRSA and MSSA, but as far as I have seen, cloxacillin, most of the time it responds to these infections, skin and soft tissue infections respond beautifully to cloxacillin in our setup in Madurai. We don't require usually vancomycin, right? So when should one suspect intracranial complications of acute bacterial rhinosinusitis? Dr. Dinesh.
So, yes, sir. So now we are moving one step forward, sir. From RP, we are entering into intracerebral complication. So whenever a child who is having eye swelling, along with he is having persistent headache and vomiting and headache that requires hospitalization, which is so severe, and vomiting that is persisting for more than 24 hours, and whoever is presenting with the altered level of consciousness and presence of any focal deficits and presence of meningeal irritations. So all those children, the complications of intracerebral complications should be suspected and they should be evaluated accordingly, sir.
Okay. So since you are running short of time, we will rush up. So coming to the end of this case, the learning points will be, so you suspect acute bacterial rhinosinusitis in any child with presence of prolonged coryza symptoms of more than 10 days duration, or severe symptoms at the onset of the disease, or double sickening, or second sickening. Our child was initially improving and again develops fever, the purulent nasal discharge, you suspect sinusitis. Timely initiation of antibiotics can prevent complications. Right? Complications of preseptal and orbital cellulitis are rare, but more common than adults, should be watched for diligently. So coming to the next case, this is a 4-year-old girl, unimmunized since birth. This child was a low birth weight baby, so the VHN had postponed vaccinating the child, and ultimately now the child is 4 years still not vaccinated. Right? So this happens very commonly in our community. Most of the low birth weight babies I am seeing don't get vaccinated. Right? So breathlessness, now the child has also breathlessness for the past 3 days. Fever for 8 days and breathlessness for 3 days. And the child is now admitted with the breathlessness of 3 days at the Dindigul Medical College, was started on antibiotics, given a unit of blood transfusion, Paxil transfusion because of hemoglobin 5 grams, and is referred for Government Rajaji Hospital for further management. Right? So what are your thoughts at this point of time, Dr. Karthik, when you receive a GRH?
A sick child, less than 5-year-old, unfortunately unvaccinated, presenting with fever, cough and cold, worsening for a breathlessness. My diagnosis will be a severe form of community acquired pneumonia, possibly Streptococcus pneumonia. So that's my take at this point of time. I need to examine the child. I may need further bloods and x-rays to comment further, sir.
Okay. So, before going to this workup, one small point is regarding this unimmunized status. One thing I would like to insist upon all the young postgraduates here is always ask for the history of immunization. Whenever you see any infant, even a little bigger child, when you see particularly any baby, when you ask for birth weight, if they say less than 2 kg, always ask the confirm whether they are vaccinated. Right? Many times what happens is, all these low birth weight babies, for some reason they get postponed. The VHN in the community, they are all blind, they have been blanketly told, don't vaccinate any low birth weight babies, there's any URI, don't vaccinate, all those silly things. And what happens is, they get postponed, ultimately parent forgets to get vaccinated the child. Right? And many a child lands up like this. So always ask for the history of vaccination. The child is not vaccinated. Before the child leaves your campus, it is only a mild URI, always vaccinate. A mild URI may not be a contraindication. In the medical college setup, you can definitely vaccinate, right? So always ask for the history of vaccination. Please remember that. So the child was worked up. Further, the child was alert, conscious, okay. But febrile, there was a pallor still. The child was dyspneic and tachypneic. The SATs were 94 degree at room air. But the air entry was reduced in left side, localized reduced air entry, hemoglobin 7.8. There was a total count was elevated with polymorphs predominance and CRP was elevated. What are your thoughts, Dr. Vasanamala? And this is the X-ray picture of this child.
So it's a case of 4-year-old with fever, cough, cold, breathlessness, and on examination the air entry decreased over the left side, and CBC total count increased, CRP increased, and X-ray showing left lower lobe consolidation with pneumonic effusion. So at this juncture, I like to say it is a community occurred pneumonia, and I first like to admit the child and proceed.
Okay. So one thing is, what will be the management plan? Once you admit, Dr. Dinesh, what will be your management plan for this child?
So, yes sir. So after admission, first we have to support the respiratory system. So we will start on HFNC or NAV based upon the respiratory distress and availability. And currently we will continue with IV ceftriaxone because it's a good drug for community acquired pneumonia, and we will see how the child goes, sir.
So one thing about bacterial pneumonia is, if you see a wheezing with crepitations, it's most likely not to be a pneumococcal pneumonia, right? Right? Wheezing in any form, wheezing with crepitations or wheezing alone is definitely not likely to be a bacterial pneumonia. It's mostly a viral pneumonia. That is one clinical clue, right, for the postgraduates. Again, this child at 40 days admission, the fever is still persisting. On HFNC, it's maintaining SATs with 40% FiO2. Air entry is significantly, it does. Even it is still more reduced, even from the time of admission on the left side, the air entry is still more reduced compared to the admission status. So, in any case of pneumonia, with the right antibiotics, the organism sensitive, within 40 to 70 hours, there should be some clinical improvement in the form of clinical symptoms like reduced fever, better appetite, the labs, the counts are coming down, the CRP is coming down, the trend is downward trend, right? The air entry should improve. But here, the fever is still persisting, worsening, temperature is rising, right? The higher oxygen status is required, the air entry is also reduced. So what next?
So this child, a community acquired pneumonia, is not responding to our appropriate antibiotic therapy. That's what we can see from the course. So all that we can think of as three things. One, whether I am dealing with a case of complicated pneumonia. Whenever a community acquired pneumonia doesn't show clinical response by 42 to 78 hours, think of complicated pneumonia in the form of any developing empyema or a lung abscess. Or am I dealing with a different pathogen? I thought it is Streptococcus pneumoniae. Could it be a mycoplasma? In a country like India, I may even handling a case of tuberculosis because an unimmunized child, BCG status is not known. Child is having a pleural effusion also. Lastly, but not the least, I have to have in back of mind whether I am dealing with a drug-resistant bug, an MRSA or beta. All these three things I have to think of. So definitely I'll be doing a X-ray chest again. If possible, if an ultrasound test is available, I will be doing. I'll be repeating the bloods and I will be sending a blood culture if not sent early. So based on this, I will plan my further management, sir.
So now the total counts are 11,000. The counts are little dropped actually, but the CRP has increased. And the culture report, blood culture report has come as MRSA. And this is the lung pig X-ray, which has worsened compared to the admission status. It has still worsened. So what next?
So here the CRP is increased from 48 to 88 and the culture report is MRSA. But the X-ray shows homogeneous opacity over the entire left side. So it is a complicated pneumonia with parapneumonic effusion. And as per the culture, I would like to add vancomycin in addition to ceftriaxone. And I would like to proceed ICD. Before that, I will go for ultrasound chest or CT chest.
Okay. So what is the role of bedside lung ultrasound? Will you consider ICD or something else, Dr. Dinesh?
Yes, sir. So before proceeding for ICD, it's better to do a lung ultrasound, sir. And because in recent times we know lung ultrasound is a highly sensitive and specific to differentiate whether it is a consolidation or a fluid. And even though it is a fluid, what type of fluid it is, whether it has simple pneumonic effusion with no loculation or it has loculations and septations. Where in case if you have loculation and septation, the child may need ICD with fibrinolytics. So before proceeding for ICD, it's better to do a lung ultrasound. And these are all the images that we have shown. In image A, we could see the black color anechoic area, which is considered as a fluid, which is not sonographically detectable, so that appears as black, and it has no septations. Whereas in B and C, we could see some septations and loculations. So for children who are presenting with B and C, definitely they need ICD with fibrinolytics. Whereas in child with A, we can go with only pleural tapping.
Yes. So one of the most common reasons for failure of improvement of symptoms, like I told, within 40 to 70 hours, the child should show some improvement. If that does not happen, the most common reason is the development of a parapneumonic effusion in a bacterial pneumonia. Right? So how are you going to do that diagnosis? Like Dr. Dinesh told, ultrasound is the better option. Right? Previously we used to do CT scan, but now the advent of bedside ultrasound in a big way, and more of our young pediatricians are well versed in doing a bedside ultrasound. Ultrasound is always a better option. Why? Because there's no risk of radiation, number one. And number two, serial monitoring is possible. We cannot do a serial monitoring with the CT chest, right? We cannot do everyday CT chest, that's not possible. But at ultrasound, you can do easily everyday monitoring, all those things are possible. So ultrasound, like Dr. Dinesh told, is a very viable option for the better patient outcomes. So cases, the antibiotics hiked, the ultrasound showed a moderate efficient septations, ICD was done, and the pleural fluid was sent for analysis. So fear is persisting. The pleural fluid which shows elevated LDH, the decreased glucose 38 mg/%. So will you suspect with this decreasing counts, right? Fever is persisting, even this antibiotic, hiked up antibiotics. Will you suspect a PVL staph aureus at this point of time, Dr. Karthi?
As of now, we are dealing a complicated staphylococcus pneumonia, which is also an MRSA, started on ceftriaxone vancomycin, on ICD also. Still, after 48 hours, still the fever is persisting, so something is going wrong. It could be a PVL producing staph. The problem in diagnosing a PVL producing staph is it's very difficult to microbiologically prove. It's not that easy to prove by a culture. You need to do a PCR for the PVL genes, which is not available readily even in Madurai as of now. So there are few clinical and biochemical markers where you can suspect PVL staph. Number one, when you are handling a child of staphylococcal pneumonia presenting with an erythematous rash or a skin lesion, PVL is a possibility. When the pneumonia is a hemorrhagic pneumonia or the child is having pulmonary hemorrhage presenting with hemoptysis, PVL staph is a possibility. And more importantly, when you have a leukopenia. In this child, the total count dropped from 15,000 to 11,000 when other parameters were increasing. Your CRP is increasing, your child has become worsened, child has become sick. You expect a total count to rise, but the total count has come down because this PVL toxin destroys your WBC. So when you handle a case of leukopenia in a staph pneumonia which is worsening when other parameters are increasing, I'll strongly suspect PVL and will add an antibiotic which acts against PVL. Sir.
Okay. So, in general, what happens usually is we are often very slow in detecting a parapneumonic effusion and even slower in doing a thoracentesis, panlama, venaman, yosite, rupam, and ultimately there's some delay in putting a chest tube. And when you put a chest tube, many times what happens, we leave it too long. That also happens. Many times what happens in a pediatric surgery department is continue the same, it happens. No offense meant, but sometimes happens. It becomes too long, we leave it too long, right? On a lighter note. So what will you do at this stage, Dr. Vasnamala?
So suspecting PVL, the drug of choice for PVL staph is clindamycin. So we have to add clindamycin to the above antibiotics. This clindamycin plays dual role, both the antibiotic and antitoxin. So it prevents the secretion of the toxin. And further, in addition, I would like to add fibrinolytics in ICD like streptokinase or alteplase due to the loculations, and to proceed further.
Okay. So in our case, again the clindamycin added and fibrinolytics were done, given. The child improved this management, fever settled, and child was weaned to nasal oxygen. So what will be the duration of antibiotics? Since our child has improved, how long we are going to treat with antibiotics? How is it going to IV? Or are you going to switch over to oral? When will we go for oral?
Yes, sir. So this is a complicated pneumonia, sir. So the duration is going to be slightly prolonged than the normal pneumonia case. For this child, it's better to give a total antibiotic duration of 6 to 8 weeks, sir. But not all necessary that all 6 weeks should be IV. Initially, we can go with IV, and after showing some improvement, we can switch to oral, sir.
Okay. So when will you switch to oral, Dr. Kad?
So as we all know, when you see a good improvement, it's highly better we stop our IV and we have to switch to oral. But remember, you continue IV antibiotics till your child is afebrile for at least 48 hours, child has respiratory stability is achieved, the child has weaned to room air. Continue IV antibiotics till your ICD is out. Having an ICD and continuing switching over to oral is highly irrational. You may land up in failure. Expect for a good oral tolerance, and you, on the back, you have to have your lab parameters showing a good improvement. So if all these criteria fits into, I will switch over to oral antibiotic and I will continue. So.
Okay. So our case improved this line of management. The vancomycin and clindamycin continued for 10 days and switched over to oral linezolid for 4 weeks. The total duration of 6 weeks was completed, right? Depending on the follow-up of it. So this is the pathway for evaluation and management of a parapneumonic effusion, right? In smaller effusions, maybe you can left alone with just empirical IV antibiotics will result in resolution of the parapneumonic effusion. But it is a moderate to massive, you always need to intervene, right, with ICD or ICD with the fibrinolytics, or sometimes in a non-responding with the VATS or thoracotype, right? I think we already overshoot our time by 10 minutes. I think we'll stop. No more cases there. I think we'll stop.
Thank you all. Thank you for the patient listening.
So to all the postgraduates there, it's always, like I told, it's very important that you not only make the right diagnosis, also think of what organisms you are dealing with and what antibiotics you are going to give, what is the dose, what is the duration. Everything makes a very important role in giving the right treatment. Thank you. Thank you for your patient listening.
Sir, to put it in a simple way as a thumb rule, the choice of fibrinolytics, or we are going to have a primary VATS, it depends on the pediatric surgeon, Dr. Vijayanand, not me. I will take the guidance of the pediatric surgeon, number one.
Yes.
But for the postgraduates, for your exam purpose, I'll tell you, when your effusion is less than half of the pneumothorax, just continue your antibiotics alone. More than half of the pneumothorax, no septations, antibiotics plus ICD. More than half of the pneumothorax with septations, antibiotics, ICD with fibrinolytics, or if you have a good surgeon like Vijay Anand to do primary VATS, you go for VATS.
So I do agree with fibrinolytics for all cases with septations. It's better to start
It's
early,
better, sir.
at the earliest.
At the earliest, sir.
And one more thing to add, chest physiotherapy is very
Yeah,
much mandatory along with
Yeah,
all ICDs.
that is one of the key things
Yes.
which helps in the drainage. It saves the remaining lung.
Yeah, we can say, because
Yeah.
as we believe before that it drains by gravity.
No.
Now it's not by gravity, it's just by expansion of the lung. So as more aggressive the physiotherapy, more earlier the recovery.
Yeah,
That
thank
is
you.
mandatory.
Thank you, sir. Thank you.
Thank you, sir. So for the postgraduates out there, the important thing is by 40 to 72 hours, you are not going to see any improvement. The most common reason is the development of a paraneumonic effusion. And it is very important that you get the early pediatric surgery referral and get their opinion and make them part of the management plan. It is very, very important. Don't leave it too long to get a pediatric surgery opinion, so that they also get in the flow of the case. So they also will know what is happening to the child. By 72 hours, you are not seeing any problem, please get a pediatric surgery opinion. Right.
Here in our resource limited settings, VATS is not available in our college, so we proceed with fibrinolytics trial. Usually we... By fibrinolytics, yes. Okay, thank you. Thank
Yes.
you all.
Thank you. The tubes. Local installations.
We have the person who does it actually. So fibrinolytics, actually it has to be instilled through your ICD. It has to be left for 2 to 3 hours. So there is a turnaround time. Depending upon the what agent you use, at times it may be for 3 days. At times you can even give it for 5 to 6 days. Sir.
Vijayanand sir, what do you use here in Rio, sir? Which
Streptokinase,
agent you use?
Which we generally use streptokinase, which is freely available, sir. Yeah. When, yeah.
You are experienced in TPA or TPA? No. Use.
Altipase is not that easily
But
available.
as per IDSA guidelines, it's a TPA which they are recommending. Very good results. Okay. But you don't use TPA in a setup like Rio also, you are not using TPA. Okay.
The reason they have told us Altiplase as first line, the reason is streptokinase, there has been reports of allergic reactions, sir. And in the later stages, a person receiving streptokinase now, and there are chances that after 10 years or 20 years, suppose for some other reason he receives streptokinase, he'll throw a bleed immediately, or some allergic reactions are more prone.
Okay.
So they have shifted from Altiplase, but still, as far as our practice, we don't find any that much of allergic reactions, sir. So we are still following streptokinase, and we are getting good results also.
Okay, fine. Because IDSA guidelines says only Altiplase. Okay.
Now the session is open to the floor. Any queries, discussions? Thank you. If there's no query, then we'll close down the session.
Thank you,
Thank
sir,
you.
and all our esteemed panelists for that enlightening discussion. I request Dr. Murugan Jayaraman to honor our moderator, Murugesh Lakshmanan, sir. I request Dr. Murugan, sir, to felicitate Dr. Karthik, sir. I request Dr. Murugan, sir, to felicitate Vasanta Malar, ma'am. I request Dr. Murugan sir to felicitate Dr. Dinesh Babu. I request Dr. Murugesa Lakshmanan sir to felicitate our chairpersons, Dr. Murugan sir. Also to felicitate Dr. Prabhakar Navamani sir and Dr. A. Parthasarathi. Thank you, sir. Thank you, ma'am. Moving forward, we now have an interesting and clinically enriching session on interesting cases in pediatric dermatology for clinicians. Dermatological conditions in children often present a unique diagnostic challenge. What may appear as a simple rash could sometimes be a manifestation of an underlying systemic illness. This case-based session will help us recognize key clinical patterns. I now invite our own pediatric dermatologist, Dr. S. Aravind, to deliver the session. I request our respected chairperson to kindly take the seat on the dais, Dr. P. Velusamy, Senior Consultant Pediatrician, Karthik Nursing Home, Dindukal. Also, I would like to request our chairperson to introduce the speaker.
Good evening. We are going to have an interesting session on skin infections in pediatric practice. We got our own friend Dr. Arvind, who is a consultant pediatric dermatologist, A Hospitals, Madurai. His area of interest, neonatal infant dermatology, genodermatosis, vascular anomalies. His achievements are publications around 44, presentations around 10. He has written 5 chapters in various journals. He has got the following medals: IADVL Gold Medal, Cuticon Pondicherry 2020, Torrent Young Scholar Award 2020, zonal and national winner. Award paper, runner-up Codificon 2019. Travel grants and scholarships during 2022. IGN, QPP Quizmaster, Cuticon, JNK 2023, Kerala 2024. He is a quiz wins and runners-up. CMC Dermo Club, Focus Dermo Pop, Onica Conference, PG Conference, Codificon, and ACI Observership in Laser and Dermatopathology. With various awards, I request our Dr. Arvind to start his session on pediatric dermatology. Thank you.
Thank you, sir. Thank you so much for your kind introduction. I thank the organizer, especially Vinod sir, for giving me this opportunity to talk. Being a dermatologist in the Hall of Pediatricians, it's a great learning opportunity, and it was enlightening listening to all the talks on various pediatric topics. So, as pediatricians, dermatologists are also probably classified as pediatric and adult dermatologists. So, I'll be sharing some cases which is much relevance in day-to-day pediatric practice. So, coming to the first case, this is a case of non-resolving persistent vulval edema in a young child. So, this was a 15-year-old female child with gradually increasing swelling of the vulva. It is of 7 months duration. It had a kind of waxing waning course, but not much of diurnal variation. No local symptoms as such, not associated with pain or any sort of tenderness or any discharge as such. Child was treated with antibiotics
and antihelminthics for filariasis at various centers without any obvious response. There were no other significant history as such. So, do any of the postgraduates want to give a guess at what the possible diagnosis is, or differential at least? Yes? Anybody from Rio wants to try? Okay, so we'll go with the investigation. On examination, you can see this vulval edema, left side more than right. There are no obvious skin lesions noted otherwise. There was a mild reactive lymphadenopathy of bilateral side, which was non-tender, of about 1 cross 1 centimeter. So ultrasound was done, which was suggestive of subcutaneous edema thickening. There was no obvious vascularity, which rules out any sort of inflammatory etiology, and lymphoscintigraphy just to rule out any obvious lymphatic obstructions. Since we are dealing with the chronic edema of sorts, we need to rule out lymphatic, which is the obvious etiology. So as dermatologists, we do skin biopsies often, so that is our go-to in need of any confirmatory diagnosis. So a skin biopsy from the vulval region was taken, and which showed lot of non-caseating granulomatous inflammation. So with this, to confirm a diagnosis, we had gone ahead with a fecal calprotectin. So this was elevated up to sorts of 800 microgram per gram. So this confirms our diagnosis of Crohn's disease. So confirming Crohn's disease, we of course need to rule out bowel involvement. So colonoscopy and biopsy is the ideal way to go. So colonoscopy showed multiple linear ulcers in the upper rectum and rectosigmoid area, and colonoscopy directed biopsy showed same sort of non-necrotizing granulomas, which confirmed the diagnosis of Crohn's disease. So this was a case of cutaneous Crohn's disease, not necessarily metastatic, because it was contiguous with bowel involvement. So further MRI showed features suggest of fistulating bowel disease, which is kind of advanced. So in this case, a combination of medical and surgical management is required with TNF-alpha inhibitors, usually under the care of medical gastro. Edema sort of resolved post-therapy. So the learning point here is you need not have obvious bowel symptoms to have IBD in case of children. So in case of even silent bowel disease, patient can have obvious cutaneous signs and symptoms. So cutaneous manifestations of Crohn's disease can be subdivided into specific as well as non-specific, which is reactive. So specific meaning when you biopsy those lesions, you tend to have granulomatous inflammation. So this can be any sort of perianal ulcers, any kind of aphthosis, metastatic Crohn's, or oral involvement like oral Crohn's, like oral facial granulomas. And reactive conditions, because of this neutrophilia, you can also have Sweet syndrome or pyoderma gangrenosum, or painful nodules over the shin, which is called as erythema nodosum. And secondary malabsorptive states can lead to other cutaneous findings because of deficiency of multivitamins and other major minerals. So coming to my second case, this is a case of hyperpigmented lesion in a twin gestation. So out of this twin, there one twin, which is a 3-month-old infant, was brought by the parents with complaints of hyperpigmented skin lesions over the trunk and extremities. This was at presentation. Mother told the child had symptoms since birth. There was a query history of some respiratory symptoms at 1 month of infancy, and fever present on and off. A child had been treated at various places outside, had these skin lesions, so was treated with the antibiotics. The skin lesions, especially mother tells, started as fluid-filled lesions like blisters, and then it ruptured and formed this sort of like hyperpigmented lesion. And predominantly it was present over the trunk, scalp area, and with palmoplantar skin peeling. Otherwise, there was no other infections in the mother. The antenatal history was uneventful. The other twin had no symptoms, was looking well. As I told, the treatment history. So this is the twin. So you can see the sort of presentation. This is a normal twin. This is the abnormal twin here. So you can see there is prominent abdominal distension. So abdominal distension suggests there is some sort of organomegaly. And you can see the cachectic look in comparison to other skin. The skin is kind of bronzely discolored, and you can see the hyperpigmented lesions. I'll show you here. So this was the hyperpigmented lesions here, and this is the peeling of skin. So this is, so in this the screening was done suspecting congenital syphilis, and the RPR came out to be positive in both the mother and child. So mother RPR was 1:16 and the infant's RPR is 1:32 and conforming with the TPHA. Ideally there should be fourfold rise in VDRL or RPR, but not necessarily in all cases. Followed up by an infantogram and CSF studies which are normal and normal blood parameters. So this was a very good case of congenital syphilis in a twin because the other twin was not affected but still had some seropositivity. So there could be some sort of discordance even in twin gestation when mother has syphilis, which is usually picked up antenatally, but then sometimes the screening goes unnoticed. So you need to kind of be on your toes to pick up these cases. So this child again, as per protocol, has been treated with aqueous crystalline penicillin for 10 days and following up with VDRL screening at 2, 4 and 6 months. And the other infant, because there was some sort of seropositivity, was still treated even if the child did not have any sort of clinical symptoms. So again we have to do contact tracing for the mother and evaluate the mother for other STIs as well. So this was post-treatment at day 10. So congenital syphilis has various signs, of which skin signs play a major role if you pick it up in the early aspect, especially in early congenital syphilis is less than 2 years and late is more than 2 years, which is mostly stigmata, which is not going to go off even if you treat at a later stage. In early syphilis, usually there is skin lesions are like secondary syphilis in older age group. So you are going to have a bronze maculopapular rash, you can have blisters which is called pemphigus syphiliticus, you can have lesions over the mucosa which is called condyloma lata or mucous patches, and the child is having this kind of URI symptoms which is called as snuffles. So they will have prominent rhinorrhea, sometimes even lead to nasal destruction and kind of saddle nose deformity as a stigmata later on. The other systemic signs of course depend on the type of hematological or neurological involvement with hepatosplenomegaly, anemia, thrombocytopenia, metaphysetis, mostly osteochondritis or periosteosis, and meningoencephalitis. This is the guideline to how to treat. I am not going to go into detail. Any child which is presenting syphilis, of course, even if it's normal, you need to do a RPR, VDRL, you need to do a serological exam. If it's positive, you need to go with the entire sort of bone as well as CSF examination to rule out any sort of syphilis in a child. And based on that, you can divide into proven or probable syphilis, possible syphilis, less likely and unlikely syphilis. So based on this, you treat the infant with aqueous crystalline penicillin or benzathine penicillin IM, and you treat the mother with benzathine penicillin IM for these cases. My third case is a recurrent facial ulceration. This is a slightly older child, adolescent. However, the symptoms started for a long period of time. So he had some sort of skin lesions since younger childhood, but then had this multiple ulcers in adolescence. So he presented with multiple non-healing ulcers over the face with generalized itching since 1 year. And he had given a prominent symptom of loss of sensations of both their hands and feet, with the classical symptoms being motor symptoms like difficulty in walking with slippage of footwear, and recurrent epistasis, which was very prominent since 3 months. So in here you can see the prominent ulcers here. You can see the ulcers primarily of the mucosa, mucocutaneous junction, and also the bilateral cheeks. You can see some sort of bony defect that is seen over the nasocartilaginous junction. And the hands give a very nice clue as to what we are dealing with. So you can see there are both sort of deformities here. So you can see a finger which is kind of inflamed or being swollen. So this is called banana fingers. So it resembles some sort of dactylitis that you are going to see in a rheumatological condition. So these are banana fingers, and then you can see some sort of trophic ulcers which is present because of any sort of anesthetic deformity or neuropathic causes. So of course we have to do a slit in this patient, and slit skin smear from usual 5 sites as recommended by NLEP. You are going to see this acid-fast bacilli clumping together in what we call as globi. So with this, the child had a BA of 6+, and just to confirm, we had gone for a biopsy, and biopsy shows this sort of what we call as foamy macrophages, and with Phytes positive acid-fast bacilli. So yeah, imaging again, just to complete, child had features suggestive of Charcot's joint. So you can see this interphalangeal erosions, bony cyst over the over the phalangeal junctions here. So this was a lepromatous leprosy. The case was put just to highlight that leprosy is very rampant in our community. So there is a lot of implication that leprosy is eliminated or eradicated, but indeed it's increasing day to day. And for matters to be worse, childhood leprosy is on the rise. Childhood leprosy is something that is an active index of disease transmission in the community. And why is it so? Because a pure neuritic or a pure cutaneous phenotype is going to be missed. It's not picked up early on in a BT stage or an indeterminate stage. It is going to progress to become a lepromatous spectrum, as we saw in this particular patient. So we initiated MBMDT. So for leprosy, we do initiate MBMDT, multibacillary therapy, based on the number of lesions. So here, it being a lepromatous lesion, it's multi-drug multibacillary therapy, not paucibacillary. And along with this, as clinically patient had severe itching, he also had scabies. Both scabies and leprosy form a continuum of neglected tropical diseases. So they go hand in hand in all these patients who neglect their own skin disease. So this is after 1 month of MBMDT. You can see the flattening of the nodules and clearing up away of the ulcers. I need to do a contact screening, especially in the community. The local PHC has to be notified, the ASHA workers has to go and inspect. Child was unvaccinated since birth, so we do sort of give immunotherapy for these children just to hasten the bacterial clearance, to reduce the risk of any sort of reactions, reactionary episodes in the future, and for hasten MDT also. So regarding childhood leprosy in children, why it matters? Because as I told, it's an active index of transmission. So it demonstrates that the disease is active in the community, and children, if they develop at a younger age, they are going to have it lifelong. So there is high chance that these children will develop irreversible deformity. So main thing for us to prevent it before any sort of anesthetic or non-anesthetic deformity occurs. So you need to pick it up early to start MDT for all these children. So as clinical features, as we know, like it's a cardinal tree. So you can either have a hypoaesthetic patch, you can have a thickened nerve bundle, or a bacillary index on slit skin smear. So any of these will confirm a diagnosis of Hansen's in a child or an adult otherwise. So based on the type of lesion, we can either go for a paucibacillary therapy or a multibacillary therapy. And in children less than 14 years, it's going to be weight based. 10 to 14 and as well as less than 10. Okay, so coming to my next case, so this is a slightly different case. This is a child in a neonate, and how does skin help us in finding a diagnosis? So this is an infant with 10-day-old neonate with generalized erythroderma. Erythroderma is nothing but any generalized erythema with some sort of either skin infiltration or any sort of redness. So the baby was hospitalized. The child was an outborn child brought with such symptoms and was in NICU, and child had severe hypernatremia in sepsis and was on supportive therapy. So dermatology consult was sought, and so what we could do in addition to all these children. So skincare is one. Child is receiving maximum support, so we need to find a etiological diagnosis. So dermatology plays a role in formulating a diagnosis in these children. So what we do is something called a dermoscopy. So we do a magnified as same as otoscopy or something. So it's a magnified lens, and it gives us a sort of details into what we are looking at. So this is the dermoscopy image of the eyebrow hairs. So eyebrow hairs in infants are very small and difficult to pick up. So I have highlighted this. You can see there is some sort of dots here. So these dots are called nodes, and this helps me to pick up these hairs and in turn do a magnified microscopy. So when I did this microscopy, you can see the hair mount showing some sort of constriction. So these are called bamboo hairs. So bamboo hairs in a child with erythroderma, especially hypernatremia, you have to suspect Netherton syndrome. So Netherton syndrome presents differently in infancy in comparison with older children. And neonatal erythroderma, there are a lot of cases where hair can serve as a clue for finding out the exact etiology in the cases. Most common causes of erythroderma being infectious, so you can have either bacterial or kind of this fungal etiology. Bacterial being toxin mediated like staphylococcal scarlet syndrome, toxin mediated toxin shock syndrome, and congenital cutaneous candidiasis, which can present at erythroderma. You can also have other various rare conditions either as part of systemic disease like metabolic disorders like any sort of inborn errors of metabolism, any sort of primary immunodeficiency like Oman syndrome or ichthyosis group of disorders is usually present with colloidal phenotype rather than erythroderma. So these are the outline of various presentations. So erythroderma, there is always some cutaneous phenotype that needs to be looked at. So fifth case is a case of reticulate pigmentation in an infant. So this was a 11-month-old male child. You can see some sort of lacy reticulate pigmentation. This was present majorly over the acral areas. You can see on the dorsum of hands and the dorsolateral aspect of the dorsomedial aspect of the bilateral foot. And this was present for 3-month duration. Child had some sort of development delay with global hypotonia. On evaluation, child had a mildly decreased HB with high MCV and pH showing macrocytosis with hypersegment neutrophils. Hence, we did a B12 level which was markedly low. We didn't go for other methylmalonic acid levels or anything. And although the infant's B12 level were low, the mother's B12 level was actually normal. So here, the diagnosis was presentation of reticulate pigmentation due to B12. And often, like in adults also, B12 deficiency leads to what we call as Addisonian pigmentation. It simulates what is seen in Addison's disease or hypocortisolism. So in this condition, we manage with vitamin B12 supplementation either oral or IM. So this child was given IM methylcobalamin daily for 10 days and weekly for 4 weeks. And with this, the child's neurological as well as cutaneous lesions resolve completely. So as you can see, so cutaneous lesions, they form a main clue for vitamin B12 deficiency, especially in children. Common causes, as you know, is usually dietary. So if mother is a strict vegetarian, probably has vitamin B12 deficiency, then probably there are high chance that child can have this sort of. Rare cases being pernicious anemia, causes of malabsorption or any sort of causes that cause other nutritional disorders as well. Clinical features can be either systemic and hematological like development delay, hypotonia, failure to thrive and irritability, and hematological being megaloblastic anemia and pancytopenia. Cutaneous phenotype can vary in children when compared with adults. So children can have mostly hyperpigmentation. In elder children, we see some sort of premature graying also. So in adolescent children, when they present with premature graying, that is also a reason because of vitamin B12 deficiency. That is a paradox because B12 causes both hyper as well as hypopigmentation. So these are mostly seen over sites of friction like over the knuckles, over the elbows and knees, and also sometimes over the sun exposed area. So any infant with these sort of cutaneous phenotype with a development delay and you need to think of vitamin B12 deficiency and has to be kept in mind. So this is my last case. So this is a acral blistering in a kid with the targeted lesion. So this was a 2-year-old female child with recurrent blistering over the dorsum of hands and feet. And child had similar lesion over the diaper area and over the gluteal aspect. So child had been treated with multiple antibiotics without any response over a period of time. Lesions were not persistent, they were intermittent. So they used to heal with some sort of this thing and then again reappear. Characteristically, this lesion started at 6 months of age after weaning was started. And there were no other systemic symptoms in this child. So when you saw, you can see the sort of blistering here with the dusky erythema. I can see some sort of vesiculation and then exfoliation happening over mainly over the dorsal of hands and feet, so over the knuckles. And child had some sort of angular cheilitis, and you can see the perianal lesions, which is classical of this particular condition. So this was at baseline. After 2 weeks, this was sent by the parents. You can see the lesions kind of dried up and become some what we call as of psoriasiform morphology, and it's very classical. So we had done a screening. So screening showed low ALP and low serum zinc levels. Zinc levels need not always correlate in this case, as it's not an ideal marker, but then can be low in such cases. So this was a case of acrodermatitis enteropathica. Child was started on elemental zinc equivalent to 3 mg per kg per day, which was just given an oral formulation. And this was after 2 weeks of therapy, the lesions have resolved completely. So acrodermatitis enteropathica rarely comes in an inherited format. It usually is acquired because of inadequate intake, malabsorption, or any sort of parenteral nutrition prematurity. And the classical triad what is talked about is periorificial dermatitis, acral dermatitis with alopecia. Alopecia doesn't always happen, with some sort of diarrhea and irritability also present. And this irritable status is first to reverse when you start zinc supplementation. Skin findings are usually acute stage starts at blistering, skin erosion, and chronic stage it progresses to a form of psoriasiform eruption. So one thing to keep in mind is acrodermatitis enteropathica like lesions can happen in other inborn errors of metabolism, like organic acidemia, for example. They can happen. So in addition, these children can also have neurological deficiencies like lethargy, seizures, encephalopathy, and they might not respond as well to zinc as you see in these cases. So you have to keep in mind biotinase deficiency, a severe form being holocarboxylase synthase, essential fatty acid deficiency, cystic fibrosis, and other sorts of dysmetabolic states. So my take-home message from each of these cases are vulval edema, isolated vulval edema can be an early marker or harbinger of IBD, especially in quiescent bowel disease in children. In twins with congenital difference, very rarely do you see so. There can be serodiscordance. Then your clinical decision making lies in whether these children have any sort of skin cutaneous, radiological, or other features. So you have to treat case to case basis, not based on guidelines. Childhood leprosy is very important, still rampant, so you have to be on your toes when you see children with hyperpigmented patches with or without any sort of hypoesthesia. These needs to be picked up and initiated MDT as soon as possible before any sort of deformity happens. Hair microscopy is a very important tool for a lot of cases in pediatric dermatology, so they can serve a clue, especially in cases of neonatal erythroderma. B12 levels to be checked in any case of infant with pigmentary anomaly need not be reticulate, it can be any sort of hyperpigmentation with sort of neurological symptoms. And zinc deficiency, of course, is important in a case of periorificial and acral blistering. Thank you.
Thank you, sir, for the highly informative and practical talk. I now request our chairperson, Dr. Velusamy, sir, to share his thoughts.
Very good presentation.
Thank you,
It's worth hearing talk. Many of our friends have left already. It's a very good presentation. Congrats, Dr. Anand.
Thank you, sir.
Over to the floor. Any doubts or suggestions, additions from the floor?
dose, ma'am. In infants, I'm not very sure. Children, in this case, we had given IM methylcobalamin initially daily for 1 week, and then weekly we had given, ma'am, based on the guidelines what we follow. You can also give oral, but just to be on the safer side, just to because for absorptive or bioavailability, IM is always better to be given in this case.
Thank you, sir.
Thank you.
Both are equally effective or parental is more effective? B12.
I prefer oral in these cases, sir. But then if you have that
Pediatric,
doubt, you can also go on IM.
Thank you.
Thank you, sir.
I request Dr. Vijayanand sir to felicitate our speaker, Dr. Aravindan, and our chairperson. I request Dr. Vijayanand sir to felicitate our chairperson, Dr. Velusamy sir. Thank you, sir. And now, one of the last segments of today's program, the postgraduate quiz. The session is coordinated by Dr. C. Vinod, Consultant Neonatologist, Rio Children's Hospital, and Dr. Akila Devi, Consultant Pediatrician, Rio Children's Hospital.
Postgraduate quiz. So totally 5 teams are participating today. All participants will get participation certificates, and first prize is 10,000 cash prize for the team plus memento and certificate. And we are just giving free registration for the state NeoCon conference registration for the winners. It's sponsored by Rio. And for the second prize, you'll get a cash prize of 5,000 plus memento and certificate. Next slide. So totally 5 teams will be participating. So team positions on the dais will be decided by lots. You need to pick a lot and you need to sit accordingly. Totally there will be 6 rounds. First 3 will start from team A through team E, and last 3 rounds will be in the reverse direction. So the stipulated time for the first 5 rounds. So these are for the first 5 rounds. The time for each question will be 30, each question to answer will be 30 seconds. The timer starts after the question has been read out. Okay. So the teams other than the team which faces the direct question has to write the answer in a separate piece of paper. Okay. So if the direct question is answered, the team will get 10 marks and other teams will not get any mark. So if the direct team doesn't answer for that question, within the 30 seconds, you all have to submit the papers with the answer written in it. So whichever team writes a correct answer will get 5 marks each. Okay. Okay, next one. So round 6 will be a rapid fire round. The total time is 60 seconds. You'll have 8 questions in that. So try to answer as many questions as possible in 60 seconds. If you don't know the answer for any question, you can just say a pass and you can attempt the other question. So if you have any time left out, so the left out questions can be answered at the end within that 60 seconds time. So 5 marks for each correct response. The others will not be getting any points for this rapid fire round when the direct question is not answered or anything. Okay. So I request Dr. Uma Devi and Dr. A.L. Gayatri from Meenakshi Mission Hospital and Research Center. So we have A, B, C, D and E. You can just take a lot and you can sit accordingly. C. Dr. M. Saranya and Dr. Zuwairia from Apollo Children's Hospital. பண்ண போறாங்க. Then Dr. Naveen Prabhu and Dr. Radhika from Velamal Medical College. D. Dr. Gayatri and Dr. Vaira Pravina from Madurai Medical College. Dr. Gayatri and Dr. Vaira Pravina. Madurai PG சொல்லியா? Madurai PG சொல்லியா? Dr. Prabhakaran and Dr. Harsha Niveta from Government Teni Medical College. A. அஸ்வத் கூப்பிடுறீங்களா? அஸ்வத் தெரியுமான்னு தான் கேட்குறாங்க. ஹலோ சொல்லுங்க. ஆமாம் சரி 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 செப்பரேட் கொடுத்துருங்க. So I think we can proceed with the quiz. So first 3 rounds, the question will start from team A. Chariya, without doubts, without clarifications, I can just ask now. Anything you have? So direct questions, you answer. 10 marks for you. If you miss, other team should.
Booklet.
Question and the 30 seconds, you all start.
So you have to write your team while writing the answer sheet. Whether your team
Just
A,
don't
team.
forget to mention your team number. Sorry, team name.
Most of the answers will be on one-word answers or choose the best like that only. So don't write elaborately. Just if the questions have any options like A, B, C, D, you write the option and write the answer also. Maybe A is what? So it's a one-word answer only. So you can write the answer. Don't just write the options alone. In case if it is out of A, B, C, D, if it is C, don't write C. You write C and what's the answer. So that it will be easy for us to correct.
A, you are from Government Teni Medical College. Team A is Government Teni Medical College. Team B is Velamal. Team A, GTMCH. Meenakshi Mission. TD is Rio. நீங்களே போட்டுறீங்களா?
Okay, shall we start? Okay, all the best. First round 1, it will start with team A. Okay.
30 seconds. Time starts.
So team A, your direct question, a 2-year-old child who received pre-exposure prophylaxis documented with rabies vaccine 5 months back has now class 3 dog bite. What is the recommendation for rabies vaccine now? You can answer. Time starts now for the other teams.
Immunoglobulin plus vaccine.
Wrong. Vaccine? Illa. Okay, sir. Wrong.
Right, wrong mein solladinga.
Okay. Time up. You can tear off the paper and give other. Answers will be announced after the end of the round. After the first round overs, answers for all the questions will be announced. So second question. Are you ready?
For team B.
Team B. A 9-month-old child was treated for Kawasaki's disease with IVIG. He is due for his MMR vaccine now. What is your recommendation?
4 weeks after the IVIG.
Wrong. I have to tell no, sir.
No. You wait for 30 seconds.
Okay.
Time is up. போட்டிருக்காங்க இல்லையா? அஸ்வத் போன மாட்டாங்க. எல்லாத்துலயுமே அப்படிதான். So direct question for team C now.
Team C, your direct question. A 20-year-old is flying to Africa for her studies 2 weeks later. As she is busy in her travel planning, she asks whether it is okay to get her the yellow fever vaccine just 1 to 2 days prior to the travel. What is your recommendation?
Seven days before the travel, she should have completed the vaccine.
Wrong.
Please write your team number. The round முடிஞ்சோனே ஆன்சர் சொல்லுங்க. சொல்லிட்டாலும் ஓகே தான். பேப்பர் கலெக்ட் பண்ணனும் சொல்லணும்.
பேப்பர் கரெக்ட் பண்ணதுக்கு அப்புறம்
ரைட் ஆர் ராங் னு மட்டும் சொல்லிக்கலாம்.
இன் கேஸ் அவங்க வந்து ஒருவேளை
ஒரே ரெஸ்பான்ஸ். ஆமா. சிங்கிள் ரெஸ்பான்ஸ்.
Whatever you are telling will be taken as the final answer. So before you tell the answer, make sure you discuss among yourself and give the final answer. Okay?
Direct question நீங்க கேக்கும்போது whatever the response you give in the first attempt will be taken into account. சரியா? ஆமா நீங்க 30 seconds முடியும்போது கூட நீங்க யோசிச்சு கூட சொல்லலாம். ஒண்ணும் பிரச்சனை இல்ல, but only one response.
Within 30 seconds திருப்பி சொன்னா எதை நம்ம எடுக்க?
Within அதான் கிடையாது, ஒரே ஆன்சர் தான்.
You can take your time. You can take your time within 30 seconds, but whatever you are telling will be the final answer which we take.
Multiple answers கிடையாது, only ஒரே single answer.
So the answer you told is not correct. Okay. Team D, your direct question. What is the recommendation for rotavirus vaccinations? First, rotavirus vaccination should not be initiated in infants of what age? Second, all dose of rotavirus vaccine should be completed within what age?
First question less than 16.
Mike.
Second.
First question.
First question.
Should not be initiated.
Less than 6 weeks.
Second question.
Should be completed within 6 months of age.
Yeah, time is up.
So your answer is not correct. Direct question to team E. 16 months old child weighing 13 kg received oral prednisolone of 1 mg per kg per day for 1 week for acute severe wheeze. He is due for his MMR second dose and DPT booster. What is your recommendation?
Can proceed with vaccination.
If you're finished, I can hand over. Yeah.
So your answer is correct. 10 marks for team E.
First round
So,
answers பார்த்துடலாம்.
so answers for the first round. So, 2-year-old child who received pre-exposure prophylaxis, which is documented, but it is 5 months before, that is more than 3 months. So, more than 3 months for class 3 bite, you have to give only vaccine. There is no requirement of monoclonal antibody or immunoglobulin, and the dose is only 2 doses, 0 and 3. Okay? If it is less than 3 months, you need not give anything for even for class 3 bite. Second question. So if you are giving IVIG, you should not give any live vaccines for 11 months. Okay? So yellow fever vaccination certificate is valid from 10 days after you vaccinate. So if at all they have to have a valid certificate, it should be given just 10 days prior. Team D. First, rotavirus should not be initiated of 15 weeks or older. So after 15 weeks of age, you should not initiate rotavirus vaccine, and all the doses should be completed within 32 weeks. Okay? So score. And your answer is correct. So if the dose is 2 mg per kg for a 10 kg child or 20 mg per day, if it is given for more than 2 weeks, you cannot give any live vaccine and from the day of discontinuation for 1 month. So killed vaccines can be given, but the efficacy will be low. But if it is less than 2 mg per kg, like what the question says, yes, you can give both live and killed vaccines. Okay? So the criteria is either the dose or duration. 2 weeks duration or dose should be 2 mg per kg in case of less than 10 kg or more than 10 kg child if it is a 20 mg per day, and if it is given for how many duration, 2 weeks cutoff. So based on that only you are going to decide. Score at the end of round 1.
Team A has scored 5 marks, Team C has scored 5 marks, and Team E has scored 15. So we'll move on to second round. Yeah, continue.
Again, second round also starts with A, B, C, D, E. So the first direct question to team A. After the completion of question, you will have the time, okay, 30 seconds. So a term well-appearing baby has a platelet count of 10,000 on day 1 of life. PT and APTT were normal. Mother's platelet count is normal. So what is your diagnosis? Alloimmune thrombocytopenia, first option. Autoimmune thrombocytopenia, congenital infections, and vitamin K deficiency bleeding.
Alloimmune thrombocytopenia.
Yeah, the time is up.
Answer is correct.
So team A gets 10 points.
So direct question to team B. A newborn presents with symmetrical intrauterine growth restriction and microcephaly. Baby also has short palpebral fissure and joint abnormalities. What is the most likely diagnosis? Congenital rubella syndrome, fetal alcohol syndrome, congenital toxoplasmosis, maternal smoking.
Fetal alcohol syndrome.
Time is up. Please hand over.
Correct. Correct.
Yeah.
Team C, your direct question. Periventricular leukomalacia is characterized by focal coagulation necrosis in the cerebellar periventricular white matter, often leading to tissue cavitation, gliosis, and dystrophic classification. Of the following, the primary cellular target in PVL is activated microglial cell, cerebrovascular endothelial cell, oligodendrocyte progenitor cell, perisynaptic astrocyte cell.
D. Perisynaptic astrocytic cell.
So not correct.
Yeah, time is up.
So team D, direct question. You are called to the postnatal ward as a baby has become cyanosed and had apnea. On your arrival, the baby is making adequate respiratory efforts, so you give a facial oxygen and he has become pink. On close examination, you notice that he has a small mouth with a protruding tongue. You inspect the oral cavity and find that he has a cleft palate. You admit him to the neonatal unit. So what is the best initial strategy to help with the patency of his airway? Nasal prongs oxygen, intubation and ventilation, nurse in prone position, tracheostomy.
C, nurse in prone position.
Your turn.
So correct.
Okay.
Team E, direct question. According to NRP, a newborn baby after initial steps Baby is found to be apneic with heart rate of 80 per minute. What is the next step? CPAP, nasal oxygen, positive pressure ventilation, chest compression.
Positive pressure ventilation, C.
So, correct.
Yeah. So round 2 is over.
So, answers. First question, it is alloimmune thrombocytopenia. Second, it is fetal alcohol syndrome. Third, it is oligodendrocyte progenitor cell. Fourth, nursing in prone position. And fifth is positive pressure ventilation.
After the end of round 2, Team A has scored 20 points, Team B 15, 1-5, Team C 5 points, Team D 15, and Team E 30 points.
So, round 3, again starting with Team A. A ventilated child with pneumonia grows Klebsiella sensitive to amikacin. So the resident plans amikacin monotherapy but is not approved by the consultant. So why is amikacin not preferred in this case? High resistance, oral formulation unavailable, poor lung penetration, short half-life.
Oral formulation unavailable. Option B.
Yeah, time is
Time
up.
up. So it's not correct. So direct question to Team B. ECMO was first successfully used in adult ARDS, cardiac surgery patients, newborn respiratory failure, trauma patients.
Cardiac surgery patients.
Time.
Yeah, time is up.
Time.
Answer?
Not correct. So Team C, your direct question. A 4-year-old child with ventilator-associated pneumonia grows carbapenem-resistant Acinetobacter baumannii, sensitive only to cholecysteine. The resident plans to start oral colistin due to poor IV access. So what will be your best response? Oral colistin is equivalent to IV. Oral colistin has good systemic absorption. Oral colistin cannot treat systemic infections. Oral colistin is preferred in children.
Option C.
Oral colistin cannot treat systemic infection.
Yeah, time is up.
So it's correct. So Team D, your direct question. A 7-year-old presents with paler petechiae, oliguria and seizures. Lab shows anemia and thrombocytopenia. The smear picture suggests hereditary spirocytosis, iron deficiency anemia, microangiopathic hemolysis, thalassemia.
C. Microangiopathic hemolysis.
Correct. So, team E, your direct question. A 5-year-old presents with fever, seizures and altered sensorium. CSF PCR is positive for HSV6. So, your drug of choice is acyclovir, valacyclovir, ganciclovir, ribavirin.
C. Ganciclovir.
Correct. So 3 rounds completed. So next round will be starting from E. Sir? E la da sir. So answers. So the first is poor lung penetration. You can't start amikacin as a monotherapy because it has poor lung penetration. Second, ECMO was first successfully used in newborn respiratory failure. So again, the oral colistin cannot treat systemic infections. So it's microangiopathic hemolysis. Again, ganciclovir is the drug of choice.
Team A has scored 20 points, Team B 15 points, Team C 15, Team D 30 and Team E 45.
So we will go to round 4. So it will be first team E. Okay. A 3-month-old female infant presented with difficulty in feeding, difficulty in breathing, cough and cold. On examination, she had tachycardia with tachypnea and severe chest retraction. She has low set ears with ptosis and short neck. There was cleft palate with cleft lip. Echo suggested VSD. So investigation shows HB of 3, platelet 70,000, total counts 3,500 and peripheral smear, macrocytic RBCs, neutropenia and thrombocytosis, iron of 198. Bone marrow biopsy showed decreased erythrocyte precursors and rest were all normal. So what is your most probable diagnosis? Pearson, hemolytic disease of newborn, transient erythroplastopenia of childhood, Diamond-Blackfan syndrome. You want to see the options?
D, ma'am. D. Option D, ma'am. Diamond-Blackfan.
Correct. So, next question, team D, direct question. A 15-day-old infant presented with complaints of loose stools of 15 to 20 episodes per day, decreased to oral intake, vomiting 8 to 10 episodes per day since day 1. On examination, the infant is lethargic, sunken eyes, AF depressed. Mother gives history of cow's milk ingestion with bottle. And the lab shows total count of 21,000, platelet of 1.5, CRP positive, sodium 120, potassium 7.8, chloride 90 and sugar was 28. So what could be the probable diagnosis with this picture? Congenital adrenal hyperplasia, pseudo-hypoaldosteronism, Liddle syndrome, septicemia. Want to see the options?
Option D, septicemia.
Other take please. So it's not correct. So team C, your direct question. A 13-month-old baby come to your hospital with recurrent sinusitis. You found the baby has a normal WBC count but no circulating B cells, small tonsils and no palpable lymph nodes. Serum IgG, A, M and E are below the 95% lower limit for the age. The most likely diagnosis is X-linked agammaglobulinemia, X-linked lymphoproliferative syndrome, Digest syndrome, common variable immunodeficiency.
Option D, common variable immunodeficiency.
Sir, wrong, it's not correct. So team B, your direct question. A 12-year-old boy was admitted to the Department of Allergy and Immunology with history of recurrent sinusitis, allergic rhinitis, allergies to nuts and conjunctivitis from 3 months of age. His medical history included severe swine flu 2 years ago, tonsillectomy, appendectomy and severe varicella. Every 2 weeks he has oral ulcers. In family history there is no evidence of any hereditary immunodeficiency or autoimmune disease. He was not regularly vaccinated. On examination he was pale, fever, febrile and has cough. No enlargement of liver and spleen with no lymph nodes. So routine parameters were normal. So what could be the diagnosis? Hyper IgM, X-linked agammaglobulinemia, IgA deficiency, common variable immunodeficiency.
IgA deficiency, ma'am.
It's not correct. So team A, your direct question. 7-year-old boy presents with malaise, chest pain and high spiking fevers and chills and right knee pain. Onset of his illness was 3 weeks previously. He has had no contacts and he has missed school during the last 1 week. Physical examination shows heartbeat of 120, temperature, he is febrile, fine maculopapular red rash on the trunk and proximal extremities with lymphadenopathy and hepatosplenomegaly. Hemoglobin of 9 and WBC count of 26,000 and platelet of 6.5. So the differential diagnosis of this are all except Sogia, lymphoma, Kawasaki, macrophage activation syndrome.
Option C, Kawasaki.
So it's not correct. Except. So we'll see the answers. So first, the answer is diamond black fan. Second, it is congenital adrenal hyperplasia. Third is X-linked agammaglobulinemia. Fourth, common variable immunodeficiency. Fifth, it is macrophage activation. The question is except. Kawasaki will have all the features. So round 5.
With 20 points, Team B is with 20 points, Team C is with 15, Team D is with 40 points, and Team E is with 60 points.
So round 5 will be a picture. Sir. Except among. Either on seeing the picture you have to tell the diagnosis, or if at all there is any questions, I will ask, you can answer. Okay?
You were 35. Of round 4, Team A is 20 points, Team B is with 25, Team C with 15, Team D with 35, and Team E with 65 points.
So round 5, again Team E direct question. So for just the diagnosis. Maybe in a single word or single option. No need of giving elaborate findings, just tell the diagnosis.
Abdominal distension at birth. This is the X-ray that was taken for that child. Newborn baby. Newborn baby born with abdominal distension.
CDH.
Loudly.
CDH, ma'am.
See?
CDH, congenital diabetes.
Team D. So, a diagnosis. You have to tell.
Ectopic testis.
Partial.
Give precise answer.
Precise. Talk loudly.
Loudly, loudly, clear.
Loudly.
Perineal testis.
Sorry?
Louder,
Whatever
please.
you are saying, please say loud.
Perineal.
Perineal? Yes.
Correct, correct.
Okay.
It's correct. Perineal
Correct,
ectopic testis.
Please talk loudly. So even if you are telling the correct answer, if you are not telling it properly, we couldn't hear. Team C, your direct question. So diagnosis.
Bladder extrophy.
Answer. Not correct. So team B. So the question is, in this diagram, how will you make higher, intermediate and lower anomaly?
With anorectal anomaly,
Have you
invertogram
identified
is
that?
done.
Question is not what is the investigation. In this investigation, how will you make out high, intermediate and low anomaly?
It's a child with anorectal anomaly, invertogram is done. How will you identify whether it is a high, intermediate or low? The pediatrician should know it. So team A, your direct question. So what is the diagnosis? How will you treat? Two portions of the question. Diagnosis, how will you treat?
Vaginal synechia.
Okay.
We have to put a cricoid incision.
Sorry? So time up. Okay. So answers. First picture the X.
Pictures மட்டும் இருக்க திரும்ப போ.
Sir?
Pictures மட்டும் திரும்ப.
Okay, sir. இல்ல treatment
option கேட்டிருந்தோம். What is the treatment for?
Diagnosis and treatment.
Okay.
Vaginal vulval synechia, labral adhesions.
Incise நாங்க open up. We'll take it as opening up.
Okay, sir.
Actually இது வந்து you can see it's an equivalent of pneumoperitoneum. In pneumoperitoneum there will be a ball of air. Here the loops are in the center with something around it. What is that? Uniform homogeneous opacification. There is a massive fluid collection. It's congenital ascites, usually due to urinary ascites or lymphatic ascites and all those things. It's just a picture of massive ascites where you can see the bowel loops floating inside, right? Next one. This is perineal ectopic testis, a type of undescended testis or malpositioned testis where it overshoots the canal to be placed in the perineal region. Next one. You came very close to it, bladder extrophy. So what is it actually? Motion is, stools are also coming through it. Can you rephrase that answer? What is that? Anyone else? Cloacal extrophy. The entire cloaca has come out. On either side, it is an opened up bladder with the bowel loops within. It's a single structure that completely protrudes out. It's a cloacal extrophy. Next one, ma'am. This is invertogram. Previously, what they used to do is they keep a radio-opaque marker in the skin and they measure the distance between the pouch and the marker. Currently, that is not being used. What we use is bony landmarks. Imagine a line is drawn between the pubic symphysis and the last spine, which is called as a PC line, and another line is drawn corresponding to the ischium, the last bone piece anteriorly. If the bowel is above the PC line, it's a high anomaly. If it is in between the two lines, it's an intermediate anomaly. If it comes below the lowermost line, it becomes the low anomaly. The total management differs, right? It's based on the bony landmarks. Next one. This is, as they have said, labial adhesions or vaginal synechia. Treatment options, not an incision, just laying it open is enough. Another option is application of steroid creams. Estrogen creams and other things can be tried, or we may just have to lay open it, right? So labial adhesions or vaginal synechia.
So next will be the rapid fire. So for the rapid fire, as I read out the question, if you know the answer, tell immediately. If you don't know, you can say it as pass. So that after the completion, if you want to go to the question which you have not answered, you can go back again.
Okay?
So after the end of round 5, Team A is with 30 points, Team B is with 25 points, Team C is with 15 points, Team D is with 45, and Team E with 65. Okay? So we are moving into the final round.
So rapid fire, first team E. So there will be 8 questions, okay? So when is the National Vaccination Day? You can answer. The program which focus in training on essential newborn care and resuscitation.
NRP.
Next question.
Next question.
Name the monoclonal antibody given to infants which provide passive immunity against RSV infection.
Ribavirin.
Sorry?
Ribavirin.
Wrong. Next question.
Tocilizumab. 3.
Length of newborn baby gets doubled by what age? Length of newborn gets doubled by what age?
4.
Correct. Which is the most common inheritable tumor in childhood?
Retinoblastoma.
Correct. Replacement dose of elemental zinc in inherited acrodermatitis enteropathica.
3 mg per kg.
Correct. What is the component of Waddell stride, that is pedestrian injury?
Pass.
In pediatric emergency, the pre-hospital care refers to the emergency care which is given by a trained emergency personnel. True or false?
True.
Correct. The program which focus on essential.
Last question.
Monoclonal antibody, whatever the questions you.
After sir.
Sir, question vaachade. Na vaachchonnaga sir. Okay, okay. Okay, sir. 1, 2, 3, 4 correct. Last question mark pannu. Mark kudukalamla sir, last question.
ஆமா டைம் முடிஞ்ச அப்புறம் தான் லாஸ்ட் क्वेश्चन ஆன்சர் பண்ணலாங்க.
But 3.
क्वेश्चन ஸ்டார்ட் பண்ணது.
So length of newborn you have told correct. 5th question was correct.
4, 5
6th
and
question
6.
was correct.
3 questions.
3 questions. So we will tell the answer immediately now itself, okay? So the National Vaccination Day is on March 16. The program which focus in training essential newborn care and resuscitation is Navjat Shishu Suraksha Karyakram. The monoclonal antibody for RSV is Nirsevimab. The length of the newborn gets doubled by 4 years. Most common inheritable tumor in childhood is retinoblastoma. Replacement dose of zinc is 3 mg per kg per day. Waddell stride include ipsilateral femoral shaft fracture, ipsilateral intrathoracic or intra-abdominal injury with contralateral head injury, and pre-hospital care is refers to the care given by the trained personnel. That is true. So now team D. So as time starts.
Please be loud and clear.
Yes, if you don't know, tell me pass, okay? World Down Syndrome Day. Focus on the program which focus on adolescent health, nutrition, sexual health and mental. Sorry?
Janani Suraksha.
Wrong. Monoclonal antibody used in eosinophilic gastritis.
Pass.
In otherwise healthy child, when will the head and chest circumference become equal? Wrong. Which gene's DNA analysis confirms Rett syndrome?
Pass.
Vitamin D content of human milk.
Pass.
Samtus triad, components of Samtus triad.
Pass.
Aplastic crisis in sickle anemia is associated with 6th disease. True or false?
True.
Wrong. Any questions you want to attempt again? So time up.
Yeah, time is up.
I think எதுவுமே இல்லை. No correct answer. So you will go for the answers. Down syndrome day is on March 21. Program on adolescent health, nutrition health is Rashtriya Kishore Swasthya Karyakram. Antibody in eosinophilic gastritis is mepolizumab. The head and chest circumference equals by 9 to 12 months. Rett syndrome DNA analysis, MECP2 gene. Vitamin D content is 40 international units per liter. Samster tried is asthma, nasal polyp and aspirin. And aplastic crisis is associated with 5th disease, not 6th disease. So team C. So no more. Team C. So when is the complementary feeding days?
Pass.
The program which focus on early intervention for children of 0 to 18 years which defects at birth, deficiency, disease and developmental delays.
DAC. District early.
Wrong. Name the FDA approved drug for long term use in sickle cell anemia in children more than 4 years.
Pass.
At what age will the child understand the concept of cause and effect?
Pass.
Which is the best first line genetic test for a child with early developmental impairment?
Pass.
What is the dose of rabies human monoclonal antibody?
20
Monoclonal
international
antibody? Wrong. What's the triad of Viscard-Ulrich syndrome?
allergy, thrombocytopenia, recurrent infections.
Correct. In children, the CNS tumors are mostly secondary tumors. True or false?
False.
Correct.
FDA.
Any questions? Time up. 2 correct answers. So the answers is complementary feeding days, June 6th. The program which focus on early identification for children with 18 years is Rashtriya Bal Swasthya Karyakram. FDA approved drug for long-term use in sickle cell anemia is Voxelotor. The child understand the concept of cause and effect at 18 months. The best genetic test is array comparative genomic hybridization. Monoclonal antibody dose is 3.33 international units per kg. Viscard-Ulrich syndrome tried is correct what you told. Eczema, recurrent infections and thrombocytopenia. And in children, the CNS tumors are mostly the primary tumors. So team D plus team B. So when is National BLS and CPR Day? The program which focus on immunization of all unvaccinated and partially vaccinated children.
Indradhanush.
Correct. Name the FDA approved gene therapy for transfusion dependent thalassemia.
Pass.
At what age will the object permanence develop?
9 months.
Wrong. Which disease is associated with congenital absence of VAS difference?
Pass.
In which stage of SMR will the height velocity peaks in boys?
Stage 4.
Correct. Cushing's triad, components of Cushing's triad.
Hypertension, raised ICP features, bradycardia.
Partially correct. Hypertension. Age less than 1 year. The duration of fever less than 24 hours. Family
True.
history of
True,
epilepsy.
true.
Wrong. So 2 correct. Yeah? Stage 4. Cushing's triad partially. Okay, we can go. Now one more thing is irregular respiration. Hypertension, bradycardia and irregular respiration. So 3 correct. So answers. National BLS and CPR Day is July 21. Mission Indradhanush is correct. FDA approved gene therapy for transfusion dependent thalassemia is Betti-Biclogen. The object permanence developed by 12 months. Congenital absence of VAS differences in cystic fibrosis. Stage 4, the height velocity peaks in boys. Cushing's triad. And this is, it is not a major criteria, age less than 1 year. Because the major criteria is, along with this, fever of 38 to 39 degrees, the major criteria. This comes in minor criteria. Okay. So team A. When is IAP Child Rights Day developed?
Pass.
The program which focus on 3 monthly visit by ASHA workers for children 3 to 5 months of age, covering complementary feeding, immunization, growth monitoring.
Pass.
Name the drug used in cystic fibrosis as a CFTR corrector to improve the trafficking of proteins.
Pass.
At what age will a child draw diamond shape?
3.5 years.
Wrong. What is the genetic abnormality seen in cat eye syndrome?
Cry to chat. 5q deletion. 5q deletion.
5q deletion. Genetic abnormality. Okay, glaucoma which begins within which age is known as the infantile or congenital glaucoma?
3 months.
Wrong. Components of Sabin's triad?
Pass.
Children with Down syndrome age 6 to 8 months are at increased risk of infantile spasm. True or false?
True.
Correct. One correct. So answers, IAP Child's Rights Day is November 20. The program is home-based care of young child, HBOC. The drug in cystic fibrosis is Lumafactor. Child draw diamond by 6 years. Genetic abnormality is partial trisomy 22. Glaucoma which begins within 3 years of age is known as the infantile or congenital glaucoma. Sabin's triad is chorioretinitis, hydrocephalus and intracranial calcification which is seen in congenital toxoplasmosis. And this is true. Children with Down syndrome 6 to 8 months of age are increased of infantile spasm. It is true. So it's completed.